Good, not good? Okay, sort of. You know, trying to fix that? Don't know how to fix that? It just starts. And it's gonna be off. Yeah. Does everybody have their slides? Yeah. All right, hold on.
Two of the most coveted places to go. They just really like you. It's sort of this kid's crushing it. That's not true. Colonel Sylvester like has a picture of you in his dad's suit. No, that's a it's like this guy's going somewhere. I gotta Gosh. I'm so excited. I feel like I got
What's after, like, how much it
I really thought they wouldn't find out about the other 4 weeks yet. Who knows? They gotta prioritize the seniors, you know.
These are all things that we're going to talk about. Okay. So hopefully you guys have your slides. Hopefully they're up and working. It looks like it's quite a bit of stuff. It's not that much. Let's understand that most of this stuff is pretty much self-limiting. So biggest things that you really have to do with diarrheal issues is make sure that they stay hydrated and supported. Alright, so really the main question becomes, what kind of review system questions do we need to ask the patient? Okay, so tell me what you guys think we should be asking about. What? All I heard was asking. Remember, I'm old and I can't hear. So what are we talking about? What kind of thing? Blood or no blood? Okay, so when we talk about this stuff, one way to differentiate this is blood or no blood. Okay, so as we go through, you guys can highlight whether this stuff is bloody or not bloody. Fever was another thing that was said. Okay, extremely important. If you know they're febrile, usually that means this is systemic. Usually, not all the time, so we have to keep that in mind. What else do you have? Fever, we talked about fever.
When did it start?
Onset, okay. Was it quick or not quick? Right? Does that leads us, was it a toxin or an endotoxin? We'll talk about that a little bit as we go through. You mentioned travel. Travel is extremely important, right? If I went to a country that has endemic diarrheal issues and you didn't take care of yourself, you may have a diarrheal issue when you come back. More than 50% of travelers that go someplace with an endemic issue usually come back with traveler's diarrhea. Right? So what other kinds of questions are we talking about? Anybody else? Anybody on this side? Simple stuff, review systems questions.
Any new foods tried recently?
Right? Did you try any new foods? Right? Great question. Right? What else? Anything else?
Is it bloody, not bloody?
We already talked about that, but that's a great one. Bloody or not bloody?
Read the list.
Consistency.
You want to talk about maybe consistency, frequency, right? Did you eat anywhere new or different? Did you start taking any new medications? Right? All these questions should be asked when you're doing your review of systems when we talk about diarrheal issues. All right? So, I'm going to hang tight here for a second. Let's see if we can fix it. We'll figure out.
Reviews.
Say again?
The next 4 hours reviews.
Oh, we do. Hey, I could do 4 hours of review assistance for GI stuff. This is one of the biggest questions list that you can really ask about. Which is why I'm asking you guys, so you guys can tell me. Because, you know, if you do have a diarrheal case, a lot of these questions can kind of sort of gear you towards, hey, what kind of diarrhea is it? Is it something that's going to be short-lived? Is it something that's going to be long? Is it something I have to give antibiotics for? Is it something I really should give fluids for? Just watch them. Watchful waiting is a thing. We could probably do that as well. Especially if they're telling us, hey, they're getting better. Right? They're getting better, and there's no need for me to really do much. So we can do a lot with this stuff. No 4 hours of review systems. Okay. So if you look at this next slide, it kind of gives you, right? So actually this slide really works out well because these are definitions of diarrhea. So if you're looking at those definitions of diarrhea, right, some of them tell you need to weigh your stuff. Who weighs their diarrhea? Right? That second definition, if you read it, at least 200 grams of dry weight of stool per day. Who does that? Right? What do you mean? Yes. So although there are some definitions to this stuff, let's stick to something a little bit more practical. The patient can decide whether or not they do anything else. So you guys like to use the word normal. There is no normal. Right? Who here uses protein and goes to the gym all the time, creatine and goes to the gym all the time? So nobody? You don't have to admit it, right? But that usually makes you go to the bathroom. Right? Who eats nothing but fiber in their diet? You should go to the bathroom more, right? So that's normal for that patient. Right? I don't do that, so that's not normal for me. Right? So there's quite a few definitions for it. But for me, to you, as provider to a patient, right, let them decide whether or not it is diarrhea or not for them. Because they're the ones that are going to tell you, oh yeah, I'm going a lot more than I'm used to. Or it's a lot watery, a lot more watery than it used to be. So once they tell you what that is, then you can go on from there, and then you can start asking all those questions. Okay? All right, so there's really 2 things that you're really going to look at. Is it chronic or is it acute? Right? So acute, less than 2 weeks. Chronic, greater than 4 weeks. Real simple, real easy. This list is not all encompassing, right? But if you look at those questions on the left, and you look at the questions on the right, they can kind of discern a little bit whether, when you talk to your patient, whether or not it is an acute issue or a chronic issue. Okay? So there's a whole bunch of things when you do review systems, questions you're going to get. Have you gone to any new places? Have you traveled outside the country? Right? Are you around anybody else that's sick? Right? Have you eaten any recent foods? New foods, right? So all those questions you can answer with acute stuff. And then on the other side, if you're thinking it's more of a chronic issue, you can ask some of those other questions. Some of these overlap, but the big deal is understanding the time limits. So less than 2 weeks, right? For acute and greater than 4 weeks for chronic. This one we're going to break out into 2 different things. We're going to break out into non-infectious. Usually the non-infectious stuff is more disease type things, such as lactose intolerance or malabsorption, versus the infectious stuff where it's viral, fungal, and parasitic. Okay. This one is probably extremely important. The reason why we put this on here was because if you do see some white blood cells or some red blood cells in a stool, that means that the mucal lining of the intestinal tract, whether it be small or large, is damaged. All right? So there's some leakage going on into the stool when you're pooping, right? So that's really what this slide is really trying to tell you, okay? This next slide is going to break it out into, you have some common themes, right? So you'll have abdominal pain, cramping, which will be a common theme. You'll have, may or may not have, fever, It'll be watery, or non-watery, bloody or non-bloody, okay? But then you'll break it out into enterotoxic and invasive. Enterotoxic meaning it's not inflammatory. If you have non-inflammatory issues, what it's gonna look like, it's gonna be watery diarrhea, okay? Generally, it's no fever, because usually with the watery stuff, the cilia of the intestinal tract usually get laid down, the junctions open up, and you start having leakage from the body. All right. So when we're talking about enterotoxic, non-inflammatory, we're talking about watery diarrhea. Generally, all your cilia lay down. Your body doesn't absorb the fluids that it's supposed to, and the junctions within your intestinal tract kind of open up a little bit and allowing some seepage to come through of the electrolytes, and you start pooping all that stuff out. Okay, that's your watery side, and that's your non-inflammatory side. On your inflammatory or invasive side, now we're talking bloody diarrhea. We're talking is going in and it's disrupting or destroying some of your intestinal tissue. Okay, so we understand as we go in and we destroy some of that intestinal tissue, you're going to get some blood seepage, right? Because the tissue is being destroyed into your stool. So there in lies why you end up with bloody stool when you talk about those types of issues. And then when you have that, you're also going to get your white blood cells in there, you get your red blood cells in there as well. That lactoferrin deposit that's in there, lactoferrin is a protein that the white blood cells put out when they're trying to destroy an infection. So that will also be seen in your stool. All right, so this next slide is basically talking more so along food poisoning. And we have 3 different food poisonings that we really talk about. We talk about the ultra short, the short, and the long incubation times. The ultra short, when we talk about ultra short, really we talk about 1 to 2 hours because it's usually chemical induced. Right? So when you go to a restaurant, you see people spraying stuff all over the tables, maybe in the back to clean stuff. Maybe some of that gets onto your food. Okay? Maybe some of the chemicals that were on the food where they cleaned, where they grew it and brought it in, and they didn't clean it well, remained on the food. So as you're eating it, the food already has some sort of chemical in it, right? Because it has some sort of toxic pesticide, cleaning agent of some sort. As soon as it gets to you, to your gut, okay, it's going to make you want to throw up. Okay? It's your body's mechanism to to protect itself. All right. So if you have those ultra short ones, we know that it's probably some sort of chemical type of abuse issue. When you have the short incubation time period of 1 to 6 hours, okay, the toxin is somewhat on your food already. It hasn't developed, it hasn't grown, it's sitting there. As soon as you eat it, once it starts getting warm in your gut, it'll start propagating, right? So it takes a little while for it to grow inside your gut, which is why it takes at least 1 to 6 hours, depending on how much toxin is on the food that you're about to eat. What does that mean? That means when you heated it up, you probably didn't heat it greater than 160 degrees, so the toxin remains. And it depends on the type of toxin. Some of those spores don't jive when you cook them. So you eat them, and the toxin forms inside your gut, and then it causes you those type of GI issues, usually diarrhea or vomiting, because it's trying to protect itself. And then the longer incubation time periods. 8 to 16 hours. And those toxins usually produced inside your body after the fact. All right, the stuff is in there, unlike the other one where it's more preformed. This one is in its infancy stage, so as it goes in there, it's going to take a lot longer for your body to allow it to grow. And then once that happens, which should be anywhere between 8 to 16 hours, they start pooping them out. Alright, that's classification for food poisoning stuff. Okay, this is just an etiology slide. The big thing here is, there it tells you 3.5 million infants develop HED annually. I can't stress enough how much you have to be aggressive when you're looking at infants with diarrhea, because they dehydrate very easily. They don't have a compensatory means like we do as adults. So you have to be very careful with those little kids. There it tells you 8 million doctor visits, 250,000 hospitalizations. Travelers' diarrhea affects 20 to 50% of travelers in developing countries. So if you have somebody that's going someplace that's endemic, they may end up coming back to see you for travelers' diarrhea. And CDC, in the U.S. scoreboard, disease causes 48 million illnesses, or 1 in 6 people, 128,000 hospitalizations, and 3,000 deaths. Now we're talking here in the U.S. Okay. And there it kind of points out that salmonella organisms account for 1 billion in medical costs and lost work time. Right? So when we think about issues with people with not just diarrhea, right? Because we're talking in general other disease processes, right? What happens when a person doesn't go to work? Right? There's secondary, tertiary effects that go along with that. Right? They don't get paid. Wherever they work, lost that production of that individual person. Right? So there's other things that can happen. And it's really bad when people are living paycheck to paycheck and they end up not going to work because they get sick. Now the other thing I tell you is San Antonio has an A through F rating of their restaurants. You usually have to post that outside their place. So I would suggest sticking to A and B type of restaurants. Otherwise you may end up as one of these type of cases. Salmonella probably being one of the bigger ones. Right? This one right here is nothing but a whole bunch of things that you can ask. Right? This goes back to what kind of questions, what kind of things do you want to know with diarrhea. And I think in clinical, you're going to have one diarrheal case, I believe. And if you guys don't have anything else to look at, you guys can look at this slide there and see what kind of questions, what kind of things you can ask. Right? Whatever reason that person came to see you, in this case it'd be diarrhea, that should be one of the longest lines that you should have for your review of systems. Right? So that you can kind of sort of pinpoint what's going on and what happened. Right? So here's a whole bunch of things that you can ask. So I kind of like this slide because it kind of groups the foods, right? The ones on the left are the foods with the possible bacteria that it could be causing the problem. All right? If they tell you what they ate, for example, they told you they ate eggs, one of the main possibilities is salmonella, right? So if you don't know how to treat salmonella, you can go into your Sanford's Guide and look up salmonella, and it'll tell you what you should treat with for salmonella. Right? So this one's kind of nice, just to give you a slight overview. Now remember, this is not all encompassing, and some of these do overlap a little bit, but at least this will give you a place to go. Okay? Same deal with this one, except for this one gives you a country, and then it gives you some predominant species in that country if people go visit and come back with some diarrheal issues. Again, not all encompassing, but it'll give you a place to start. C. difficile, and how you get it, generally from hospitalization. Or antibiotic administration is probably one of the bigger ones for more healthy folks. The way you get this is you take an antibiotic, things indiscriminate, kills everything in your gut, and then some of the bad stuff kind of sort of overwhelms the good stuff. Right? Until the body comes back online, then you may end up with some diarrheal issues. Pseudomonas usually you'll see it with liver disease or malignancy. Right? It's one of those gram-negative rods. That thing you can get from freshwater fish, shellfish, cattle, goats. So there's a lot of places you can actually get that PM1 species. Salmonella, and if you have intestinal dysmobility, right, that allows the stuff to stay in the gut longer, which allows that salmonella species to grow a little bigger. So everything on the right kind of gives you those folks that are at risk for the species. Rotavirus hospitalization, because rotavirus is really infectious. Okay. All right. So what are you going to look at physically? Okay. Make sure you look at the person. Does the person look dehydrated? Right? How do we do that? We look at skin turgor. Okay? Just skin on the back of the hand. Does it go back down? Yes or no? Does. Great. Wonderful. Probably not as dehydrated as you think. Right? Look at the eyes. They look sunken in. Right? Look at the face. See if it's emasculated. Right? So make sure you take a look at your patient. Right? When you're doing your exams. Right? Your abdominal exam, you're always going to look, listen, feel, right? Look, listen, feel. Right? So you're going to look, is it bloated? Is it swollen? Is it, you know, a lot larger than it's supposed to be? Right? You're going to listen in all four quadrants with your stethoscope. You hear any gorging, right? Gut grumbling. Right? You're going to percuss. Does it sound like it's solid? Does it sound like it's FOS? You guys know what FOS is? Yes, okay. So I'm saying, you know that part. All right? That's one of those things that you do when you concuss, right? See if they're full of fluid or full of doo-doo. Right? Okay. Then you're going to palpate, right? Which will read out tenders, do all your special tests and all that other good stuff, light view. Okay? And then you need to do a rectal exam. Yes? Maybe? No? There's no way in hell I'm going to touch that? Next semester, you're definitely going to do one live one before you go to phase 2. Okay? So we'll do a rectal exam. Okay? So those of you with big fingers, they're not going to like it. Those with slim fingers, they may like it. Those with long fingers, you may be able to tickle their tongue. So the question is, do you do it or not? Yes or no? Say again? Okay, so technically, book answer is yes, right? That is a complete abdominal exam. Complete abdominal exam includes a rectal exam. Sure it is. But you are correct, sir. Medicine is a little gray. Now, I will tell you 3 reasons why we do a note, and one of them is for legal reasons. If you did not do a rectal exam, something happens, and it would have been caught if you did do a rectal exam. And you end up going to court and there's not one documented. Guess who just lost that lawsuit? Okay? So if it's not documented, it didn't happen. If it's related to why you're being sued, you just lost the case because you didn't document something that you should. Right? So remember that. When it's like, do I need to do a rectal exam? Provide a preference, right? Depending upon what's happening. All right, this next one is non-specific signs and symptoms. Really, it depends on the severity of the diarrheal case when they show up at your doorstep. Right? Is he lethargic? Is he depressed? Conscious issues, right? Is he in and out? Does he have dry mucous area, membranes? Does his eyes look something, right? So these are the things that you're looking at to determine what that patient is supposed to look like, right? If he has all these things, then his severity is probably high, which means you probably should give him some fluids. You guys know what the tilt test is? Yes. Yes. Yes? No. Okay.
Not afraid.
So, two things. Really what we're doing, we're just checking to see if you're going to have a drop in systolic or diastolic. Systolic more than 20, diastolic more than 10, when you go from laying down to sitting up or standing up. Okay? If your numbers drop more than 10, diastolically, or more than 20, systolically, then the likelihood of being dehydrated is high. In which case you can just say, hey, I'm just going to go ahead and give you an IV. Or, what is the best way to rehydrate? Orally. Not what, but how. Orally is the best way to rehydrate. So if your person can tolerate fluids orally, then have them drink fluids. Okay? It isn't about sticking someone with an IV just because you want to stick them with an IV. Got it? Okay? If they're extremely severe, then go for it, knock it out. But if they can tolerate fluids orally, then let them tolerate fluids orally. That is the best way for someone to rehydrate. And here you can have non-focal abdominal pain, cramping, gorging. That's the rumbling in the stomach that you're actually hearing when you're putting the stethoscope on the belly. You'll have perianal urethema, fever. Usually with systemic or invasive type issues with the GI tract. All right, and if you do have chronic issues, right, that's very much 4 weeks, you may have some muscle wasting. All right. Okay. The other big thing is if you're not looking at the rectum and they're telling you they're not sure, they thought they saw some blood in their stool, right? Because one of the questions you ask, hey, have you had bloody stool? And they say, I don't know. Or they say, I saw some red drops, maybe, I don't know. Right? Simplest thing to do is look, right? Because maybe it's just a tear, right? Maybe it's just a fissure. So if you don't look, you may miss things. So make sure that you take a look if they're not quite sure. Okay? There's a whole bunch of non-specific labs that we can do. All right? There are a whole bunch for GI. In this case right here, we're probably going to do a whole bunch of culture sensitivity. Okay? For the bad ones. For the ones that are self-limited, usually we don't do anything. We just watch them. Make sure we do supportive care. Make sure they stay hydrated. If they have any kind of fever, you can give them acetaminophen, and you just keep an eye on them. All right? But there are a whole bunch of different things that we can do. You guys know what a string test is? Yeah, let's follow a string and keep it in there.
Yeah.
That's nasty. Alright. So this one basically tells you oral rehydration is the key. Right? Oral rehydration is the key. Generally, we're just going to treat symptomatically. If we need to, we can do an IV if we need to. Generally not always the case, right? And then people are always like, well, what do I need to do? Kind of controversial. You guys know what the brat diet is? You know, bread, rice, applesauce, toast. Okay? So generally we'll try to allow that person to relax their belly. This stuff doesn't usually cause much belly to work, to break stuff down. So usually we tell them this for a couple of days so that their belly can relax, and then usually the body will take over and take care of itself. Now this is where we go back and forth, depending upon whom we talk to. Anti-motility agents. Do not feel compelled to give somebody anti-motility agents. You know what those are? And you guys talk about that stuff in farm, right? The book answer for anti-motility agents is at least 48 hours. Book answer, at least 48 hours status post beginning diarrhea. I usually wait 48, 72 hours. So here's the thing. If you're wrong, you just screwed that person up, right? Because your body right now is trying to make it go. It's trying to expel all the bad stuff. If you give them an anti-motility agent, you're going to stop or slow down the peristalsis of the gut. when you do that, that's great, you just stopped their diarrhea, but guess what you just caused?
Bacterial growth?
Not just a lawsuit, but you just caused the problem to get worse. Because all that bacteria that the body was trying to blow out, pun intended, right? It's not, and it's harboring inside the belly, inside the body, inside the intestinal tract. Okay? So that person's gonna get worse. So if that person's your patient, now you just make the patient worse. Now you gotta deal with something worse than he initially had, just because you wanted to stop his diarrhea. Right? So you have to be careful with that time frame. You have to be careful if you're gonna give him something. Like I said, watchful waiting, that means that I don't do anything. I just watch and give you some tips of oral rehydration and supportive care. Right? Especially if you tell me that you're getting better. So you gotta be careful with that. And then you have the antimicrobial agents, whether they're bacteriostatic or bactericidal. Be careful, make sure that you do a good history and physical so that you know whether or not they do need an antibiotic or not. Right? There are some things that are starting to become resistant to some of our antibiotics, and we don't want to go beyond that part. We don't want to be contributing to that either. Right? There's a whole bunch of different things that can be causing GI and diarrheal type issues. A whole bunch of different organisms. As you saw in those other lists, there was a whole bunch of different organisms associated with foods, associated with different countries. So some of these are very self-limiting, and you don't even have to worry about it. Some of them we don't even identify. We just treat, because they're self-limiting, make sure we do supportive care, and people really get better. Now, who are the most people at risk? Generally infants, right? Because they don't have that compensatory motion, they're straight, they're good, and then they just fall off a cliff. We don't, we're good, and then we start steadily going down the hill, right? For compensation with this. Same thing with the elderly greater than 65, okay? They will present a little bit different. They may not have some of the normal symptoms that we normally have. So we have to remember, they may present a little bit different. And just like children, sometimes they hit a point in time and then they just fall off the edge. I'm talking more so with the dehydration aspect of this. If we can't identify the species because it is something bad, right? Like salmonella, for example, because salmonella can cause salmonella paratyphi or typhi, okay, which is really, really bad. And that is a notifiable disease, so we've got to tell folks, hey, this is what we got. Right? So then the government will go ahead and start doing all this tracing and tracking for public health, if we need to. And some of them are kind of hard to differentiate because they kind of overlap with each other. Alright? So acute gastroenteritis, that is a general standard term that we use for a whole bunch of these things. The next, I want to say maybe 8 slides or so, are going to be a whole bunch of different little diseases, but all those still fall under acute gastroenteritis. And all that is just an inflammation of the stomach or the intestinal lining. Something caused it. What it is, sometimes it doesn't matter because it's self-limiting, okay? But it does cause a diarrhea, it does cause a vomiting, it does cause abdominal pain. Okay? Sometimes fever, depending upon which one it is, okay? Especially if it becomes invasive. Okay? Alright, so 14-hour incubation period, plus or minus. Okay, it could be less, it could be more. Okay, that isn't a hard number, because it really depends on which acute gastroenteritis process we're talking about. Okay. Here it says on average 3 days. Again, depending upon which one it is, some will go a little longer, 7 to 10, some will go a little less, 1 to 3. Alright, so that 3 there is kind of an average. And the ones we're going to talk about, they're bacterial one-sides, Longitudinal longitudinals. A lot of the stuff that we're going to look at right now is going to be more based on how they get it, keeping other people from getting it, and just watching them until they get better. All right. All right, so the first one we're going to talk about is adenovirus. What does the adenovirus cause? Every year, it's a whole bunch of people. Not diarrhea. What is it? Upper respiratory. Okay, so it usually causes the common cold. Okay, adenovirus usually causes common cold. But guess what? If it cuts into your GI system, it'll also cause you diarrheal issues. Alright? So that's what this is telling you. How is this spread? Fecal oral. Fecal oral is how you get the adenovirus. Alright? The specific serotypes are 40-41. Those are the most common ones that cause you the diarrheal issues. And there it says causes multiple viral illnesses along with gastroenteritis. Part of that is the common cold. Okay, it can also cause pink eye. It causes a whole bunch of different stuff. Okay. Here it says diarrhea is more prolonged course than rotavirus. It's moderately contagious. Okay, so some of these we need to keep in mind of how contagious they are, because the more contagious they are, the more we really want to try to isolate them so they don't spread it to other folks. Okay. This thing says it'll last 1 to 2 weeks. Just like the common cold, 1 to 2 weeks, right? Okay, it affects all ages. More severe in young children, we've talked about that before, but we're really talking about dehydration issues. Alright? It can happen all year round, and it's supportive care. That's all you're going to do. You're not going to do anything. And this thing, especially when it's fecal oral, you're supposed to wash your hands, right? Wash your hands. And you'll notice that throughout this entire thing for diarrheal issues, washing your hands is one of those key things, because a lot of this isn't just inhalation anymore. Now we're talking fecal oral transmission. Now if you're going to the bathroom, and then you're preparing food, and you're spreading it to other folks, right? So hand hygiene is extremely important. All right, calcivirus. This is moderate to severe gastroenteritis. All right, same deal, fecal oral, right? Nothing different. This one, again, unlike the other, is highly contagious. All right, so if someone you think has this, you may want to tell them, hey, you need to kind of isolate yourself. You're the only one that's used that one bathroom until you start getting better. Okay? The nice thing about this is that it only lasts 2 to 3 days. These are averages. It's not going to be, oh, you want to be on that day. You can't be that. These are averages, right? And a lot of this depends on how much calcivirus did you get. How good is your immune system? Are you taking any medications that are going to suppress your immune system, like chronic steroid use? So there's a lot of depends that go into how long this stuff usually lasts. In this case, our average days are 2 to 3 days. It affects all ages, all year round, just like the last one. Just like the last one, supportive care and hygiene. So far, these guys have all been self-limiting, so you don't have to really concern yourself about it. I would highlight this one, because I would use this one as one of those test scenario questions. All right? Why? Because this is one of those big ones that you always hear about. Okay? Norovirus is one of those big ones. It is the #1 cause of adult AGE. Keyword, adult AGE. Incubation period, generally about 6 to 48 hours. This is highly infectious. This is usually what happens on cruise ships. People just start spreading it to each other, and then you have a poop cruise, right? And usually that's on the news. Okay? This is so highly infectious that you may only need 10 virons in order to get infected. Okay? That is a very low number. That is a very low number. The other big reason why this is so highly contagious is because you start shedding. After you feel better, 1 to 3 days, feel better after day 3. You may still shed the virus from anywhere between 3 days to 4 weeks after you get better. Which means even after you feel better and get better, you can still spread it to other folks because you may still be shedding the virus in your poop. Okay? One of the reasons why this thing is so highly infectious. Okay? So even after you get better, you're still spreading it. So you gotta be careful with that. Right? Watery diarrhea, not bloody diarrhea. None of these have been bloody. They've all been watery thus far. Okay? But then again, they've all been self-limiting, just like this one is. Right? And there it tells you cruise ship outbreaks. The last 1 to 3 days. Direct contact with infected person or contaminated food or water. Okay? Rapidly spreads through the environment. Especially if you don't have good hand hygiene. You start touching stuff or you start touching other people, you spread the virus. Affects all ages, severe and young and elderly, so nothing different. The young and the elderly. If we can try to isolate them, hey, you're the only one that needs to use this toilet. Hey, you stay over here away from everybody else. Make sure you wash your hands, for at least the next 3 to 5 days, so that we try to keep down the spread of the issue. Okay, supportive care and hygiene. Supportive care and hygiene. Pretty easy, right? Biggest deal is rehydration. All of these cases is rehydration. Alright. Cruises, usually you may want to check the food areas. Everybody's doing the right thing back there by washing their hands. Now, if you see the bottom there, it says alcohol-based sanitizers do not kill norovirus. Okay. This thing is highly resistant to alcohol-based sanitizers. The problem with this is that it has no viral envelope. The viral envelope is what surrounds the outside portion of the virus. And the main job of alcohol sanitizer is to disrupt that envelope on the outside portion of whatever virus is trying to kill, or bacteria is trying to kill. Because this one lacks that, there's nothing for the alcohol to go in and disrupt. So it makes it a lot more difficult for alcohol-based sanitizers to actually get rid of this thing. So people are saying, well, I'm using the alcohol-based sanitizer. Is that okay? No, it's not okay. Because the alcohol-based sanitizer is not going to make that particular virus go away. Hand washing is key. Hand hygiene is key. Nothing that we have beats hand hygiene. Alright? But this case specifically, resistant against alcohol sanitizer. Okay, this is what you're going to end up looking like. Right, can come out of both ends. On average, it's about 30% if you're wrong. Okay, usually it's mostly just highlighted. Right. So this one I would also highlight. All right. Generally, in children less than 2 years old, outbreaks usually occur in the winter. Okay. Viruses usually occur between November and April. That's the most common time for viruses to occur. Okay, this usually lasts about 48 hours. Same deal with this one, it's fecal oral. Most common cause of diarrhea in infants and children worldwide. Most common cause of diarrhea illness in children worldwide. This kills a lot of people in developing countries, not here. In developing countries, this thing kills a lot of infants because they are not set up medically to handle a lot of these cases. They don't have a lot of medical supplies overseas in certain places where this really occurs. So this thing does, affect a lot of animals. Associated with most deaths from diarrhea in developing countries. Okay, typically, fecal oral may last 7 to 10 days, and there lies the problem, right? Especially for infants, because now we're talking 7 to 10 days of of dehydration for that infant if you can't fill them full of fluids and they don't eat or drink. Seasonal winter outbreaks, right? And then November to April, can be when those viruses usually occur. And then it's highly contagious, just like norovirus. And there's a vaccine available worldwide. I believe in 2006 is when they released it. It is a live vaccine. The World Health Organization is trying to spread it worldwide, but you know, it's an ongoing effort. Just like norovirus, rotavirus, does the same thing. Even after you're better, after 7 or 10 days, you can still shed that virus in your stool, right? Spreading it to other folks. Okay. So remember cytomegalovirus. Who does that affect? Compromised, right? Does it affect us? Sometimes. But its main target, because CMV is considered an opportunistic infection, okay? It usually targets immunocompromised folks. Here it tells you Crohn's folks, anyone really with GI issues that gets this into their GI system and they affect. Alright? Big deal is that anywhere between 50% to 90% of us, when I say us, I mean us healthy people, have CMV already in our system. Okay? We're healthy, so it maintains that CMV at bay. We don't usually have any issues with CMV unless we become compromised or our immune system drops. So this stuff usually affects those folks that are immunosuppressed. And it usually causes them diarrheal issues. When we're talking those immunosuppressed folks, remember, they have minimal means of fighting against pathogens. So when this gets in their system, this is going to run rampant. Okay? It's going to get in the system, they're going to do whatever it can do. So this one can become invasive. Not necessarily those healthy folks, but in the immunocompromised folks. Okay? And when I say invasive, means it's going to get into the intestinal lining, it's going to start eating away at the mucosal walls, and it's going to try to become systemic. And when it becomes systemic, it's going to go to every other organ in the body that it chooses. Right? And if you remember the HIV one, most common is the eyes. So this thing will go towards the eyes and the liver. Right? Because that's sort of where it likes to go. Right? But understand that it can affect every other organ in the body as well. So we have to be very careful with those guys. And as you can see there, it produces watery to bloody stool. And when I say bloody, probably because it's become invasive and it's eating away at the intestinal lining. All right? And it's allowed some of that blood to fall into the stool. Okay. This is probably one of the only ones that we're going to talk about that actually you can treat with an antiviral. So it'll be Cancyclovir is usually what we'll use. If you remember, usually cytomegalovirus doesn't infect AIDS patients until they're less than 100 CD4 count. So a lot of these things we need to align together to say, oh, yeah, probably going to affect them this way. We need to be a little bit more aggressive. Now, ultimately, there's an understanding that this thing can become invasive. It can cause like serious things like megacolon or sepsis. If it does cause those issues, they need to be hospitalized. If it causes megacolon, they may have to be, that is a surgical emergency, so they definitely have to be in the hospital. So we have to be very careful with these guys. And we have to be very aggressive and stay on top of the immunocompromised people that get sick with this. Yersinia, usually associated with eating raw or undercooked pork. So something to highlight. Actually, you know what? Let's go ahead and take it. New Claude's laptop. We hope that it's working well. And we will hook it up to see if we can get rid of this. Jack. Alright. But for now, we'll continue to drive on. Right now, we're on slide 30 for Yersinia enterolytica. Yersinia enterolytica is caused about 117,000 diarrheal illnesses, about 640 hospitalizations, and about 35 deaths here in the U.S. every year. So you may see a lot of these. Children are affected more than adults. Okay, so I hope you highlighted that first part, usually associated with eating raw or uncooked pork. Symptoms usually occur within a week of exposure, may last 1 to 3 weeks. So understand that this one may cause some serious issues because of the length of diarrheal issue that you may have. Acute onset, the other thing that you can highlight with this one, I think we only have 2 that have that possible pseudoappendicitis. So that's something else you can probably highlight for this one. Typically, acute onset may have abdominal pain localized to right lower quadrant, which can lead to pseudoappendicitis. Now, with some of these, you're going to have other possible side effects. If it is invasive or it does become systemic in some way, it may spread to something else. A lot of these, like the joints. So sometimes one of those host issues may be an arthritis of some sort. In this case, if it does become systemic, it'll cause some possible polyarthritis. So it is a possibility, but what do? Treat supportively. If this does become moderate to severe, then we will treat with Cipro or trimethoprim, something like this. This one is a notifiable nationwide one, so if you do have a Yersinia enterolytica, you gotta let public health know. And they'll do their own little tracing. This thing is self-limiting, so you don't have to give antibiotics. But remember, the folks that are susceptible to this may become severe and may become systemic. So definitely treat those folks. Staph aureus, you guys remember that stuff lives on our skin normally, stuff lives in our nose. Usually we're asymptomatic, no issues, no problems. Right? This one releases a toxin inside of our body. If we ingest it, okay, it'll cause us to start urination. Sudden onset of nausea, vomiting, cramping, diarrhea, often between 30 minutes and 8 hours of eating or drinking something contaminated with the Staphylococcus toxin. Right? This thing does release a toxin in the body that will cause us a problem. Nice thing about this thing is usually it only lasts 24 hours. It's like a 24-hour stomach bug. Okay? Supportive care is generally all we do. And most of these, usually diagnosis is just clinical. This one is just clinical. By the time you do anything, when you show up in your office, you're probably already better. Right? It takes them, in a good day, in a minimum of 24 hours before they see someone. That's in the military. Usually it's a lot longer time period than civilian something. Okay. So supportive care, oral rehydration if possible, or IV if needed, but generally oral rehydration. You do get nauseous with this thing, so you may want to think of some antiemetics. Bacillus cereus. You guys usually always remember this for some strange reason. Rejection fluid are multiple. Usually when foods are left, rice or pastas, starchy type foods, when they're left outside at room temperature for long periods of time, it's usually when the toxic appears in the bacillus. Okay? It's really most commonly associated with rice. It's not all rice, but most commonly associated with rice. So for some strange reason, you guys always remember this one particularly. So this one's always usually 100% question on most tests. But this one usually causes an enterotoxin, okay, which will cause you a diarrheal issue. Now, and that one can usually start about 15 hours after ingestion. But there's two different types. We have the emetic and we have the diarrheal. Alright? So the diarrheal one usually starts about 15 hours after you consume it. Usually you produce toxin in your small intestines. And because you're producing it in your small intestines, it's usually why it's causing you a diarrheal issue. So you ate something that didn't start propagating until after it got to your gut, and you're pooping it out, right? So the thing with most of these is that they're spores. When you ingest a spore, this one particularly, the gastric acids in your gut doesn't kill it, right? That's part of what the gastric gases or the gastric acid should be doing in your gut. But because the spore has a shell on it, it really doesn't kill that shell, so it makes it into your gut. And once it gets into your gut, that shell opens up because of the heat of your body, and then it starts propagating in your intestinal tract. Alright? For the emetic one, the toxin is already in the food. And that toxin that B. cereus is making, you have apparently left it out so long that the toxin was able to build up enough in the food that as soon as you ate it, your body realized that it was a toxin, and it was just, hey, I don't like this. Okay? So you have two forms, you have the emetic form and you have the diarrheal form. Anywhere between 30 minutes to 15 hours. The reason why that's so long is because it's really dependent on which form you have. Do you have the diarrheal form or do you have the emetic? Okay? So that's pretty quick. Usually it lasts about 24 hours. Right? So another stomach 24-hour bug. Okay? Usually these folks don't. Usually come see you. Treatment is symptomatic. There's really nothing else you do other than oral hydration if possible. Just throwing stuff up and think of antiemetics. And then if they are bad and they do end up coming to see you more than a 24-hour time period, then you've got Cipro or trimethoprim or something like that. Yes, sir.
I just want to make sure that ours don't talk about emetic versus diarrheal.
No, it's not on the slide. That's me telling you why this thing goes anywhere between 30 minutes to 15 hours. Because that's a huge range. And sometimes when we have big ranges, we need to understand why they're so big. And in this case, the reason why is because we have the two different things. We have the emetic and we have the diarrheal. Right? And then the other thing we can talk about is that food safety, right? We gotta keep your foods below 40 degrees and above 140 for storage. This way when we get stuff, and cooking them generally should be greater than, I think, 160. But none of that stuff is on there, but it's more so for your overall awareness. Clostridium perfringens, okay? It's a common cause of food poisoning. Generally, we know C. perfringens as something that causes gas gangrene. So when we look at amputations or other bacterial type infections, gas gangrene usually forms right under the skin. That's usually why we know that Clostridium perfringens. But in this case, it's oral C. perfringens, and that's what's causing your GI symptoms. Here it says it's mild gastrointestinal symptoms, usually associated with foods high in starch and protein. Right? Same deal as B. cereus, usually foods high in starch and protein. Usually occurs 6 to 24 hours, and they last up to 24 hours. Okay, so this one again, up to 24 hours. Right? Generally not contagious. Treatment supported. Right? So not too bad. It's pretty simple. The big one that we need to keep in mind with C. perfringens is that it usually happens where people make large amounts of food. Okay? So if we're talking hospitals, if we're talking dining facility down the road here, right? If we're talking cafeterias, prisons, and nursing homes, is where we think about C. perfringens. Okay? Now go back to jejuni. Okay, it's one of the most common causes of foodborne illnesses in humans. Right? It's typically found in intestines of animals, particularly poultry. So this one really think about chickens. Okay? But it can be transmitted to human through consumption of contaminated food or water. Okay? 2 million cases annually, transmitted fecal oral. Right? Chickens account for 50 to 70% of this transmission. Right? So when these chickens are prepared, obviously not prepared appropriately, and that's how we end up getting sick. Other causes of some of these outbreaks are sick pets. Pets can make you sick if they're habit. Okay? They can spread it to you. The incubation period is generally about 2 to 5 days. And other things to think about: unpasteurized milk, another possibility that can spread Campylobacter. There's some signs and symptoms. Patient usually looks pretty ill when they show up to you. Alright? We don't usually say too much about a lot of those, but in this case, this person usually looks pretty ill. Here's another one, right? So this is probably your second one. You'll have, this one says right or left. Lower quadrant pain, but it also seems like it'll cause a possibility of pseudoappendicitis. Alright, so another thing that you can highlight to differentiate. Another thing to highlight would be, this one doesn't usually cause abdominal pain per se. Especially when you compare it to Salmonella or Shigella, where well, this one has abdominal pain. Excuse me, this one has abdominal pain, unlike Salmonella or Shigella, where those guys usually have no abdominal pain. And so that is a way to differentiate it from some of the other ones. There you have a high fever, 104. Headache, myalgia, 10 watery, bloody bowel movements. 10 plus. So this one's going to give you a lot of watery diarrhea and blood. So that is something else that you probably should highlight. Lots of watery, bloody bowel movements. Diagnosis. For most of these, it's usually you just take your stool samples and send them off. My recommendation for you would be dual culture and sensitivity when you send off those stool samples. Some of these have some resistance. So at least if you do the sensitivity aspect, they will tell you what kind of medications you may need if you come up against something that's resistant. You can do microscopic stuff. If you do microscopic stuff, and you look at it on a microscope, it'll look like a little column. It'll look like a little backwards. Here's what it looks like. Most of these folks usually recover with no issues. Usually don't do any cultures. And if you're going to treat, you treat with azithromycin. Salmonella. 2,300 different Salmonella seromods. That's a lot, right? Really, we group them all together. You don't necessarily differentiate much of them. But this is one of the most common foodborne illnesses that we usually contract by either contaminated food or contaminated water. It usually causes diarrheal symptoms, abdominal cramps, fever, vomiting. Okay, this is the general Salmonella serovirus, aside typhi and paratyphi. Those two are going to be very different. We'll talk about those next. Those two are both Salmonella species, but those two are okay. This one's not as bad. Those other two, we'll get to them in the next section here. They're pretty bad. So things to highlight here. Sources. Okay. Here they're giving you pets and reptiles. We haven't had that very much here, right? So that's something to highlight. And there's the 95% of the foodborne illnesses are associated with those five: eggs, poultry, vegetables, cheese, and peel fruit. Okay. I don't peel fruits usually because it's been washed and contaminated. There's a whole bunch more reptiles and amphibians that are associated with transmitting salmonella. So these are all things to highlight because this is a little bit different than some of the other transmission modes, right? So signs and symptoms of this salmonella serum: non-bloody loose stool or watery diarrhea. Key here is watery diarrhea. Right? 12 to 36 hours following exposure, nausea, vomiting, mild abdominal pain. Rare symptoms like cholera. Okay, when we say cholera-like diarrhea, what that means is that when you go to the bathroom with watery diarrhea, keyword watery, you go a lot. And when I mean a lot, I mean like you probably fill a bucket of liquid. Alright? And then you may end up with some tenesmus. Tenesmus really just means that you feel like you gotta go, but there's nothing for you to do. Nothing happens. Right? Diagnosis, area test culture for non-typhoidal salmonella. Usually about 90% you can get isolation on that culture, but we really don't do too much. It's usually resolved without treatment after 1 to 7 days. If your patient does become moderate to severe, then you can use Cipro. Make sure that supportive care is for all of these. Okay, supportive care is for all of these. Typhoid fever. So this is the back. Okay. Typhoid fever is caused by Salmonella typhi or Salmonella paratyphi. Salmonella paratyphi is a little brother or little cousin of Salmonella typhi. Right? So they're going to really produce the same symptoms. It's just going to be a little bit less severe than Salmonella typhi. These are what we call endemic fever diseases, and that really encompasses both Salmonella typhi and paratyphus. These are the same as the other ones. They're consuming contaminated food or water is hygienic. Person-to-person fecal orally, same deal. If you put this on some surfaces, other people can pick it up off the surfaces as well. So another reason for strict hand hygiene. If you do not treat this stuff can be life-threatening. And that's how severe typhoid fever can be. In the U.S., we generally do not see this, but what does happen is these guys go to an endemic place with typhoid, and then they come back, and then they end up having typhoid here, and that's something that we're generally not used to seeing. Right? And here it says 70% of travelers usually get it. Remember the folks that are at risk, young children. Right? If you go to a country that has overcrowding and poor sanitation, your likelihood of picking up typhoid is extremely high. So understand the locations that you go to really bear on whether or not you're going to get this or not. So foodborne transmission, food contaminated with feces in urine. Okay. So here's your hallmark of typhoid fever. Even though most of these attack the mononuclear phagocytic cells, okay, those mononuclear phagocytic cells are usually found in the liver, lymph nodes, spleen, and prior patches of the ileum. Prior patches are little nodes or clumps of lymphoid tissue throughout your small intestine. You have it in your proximal, middle, and distal areas. Your distal area of your small intestine usually has the biggest conglomerate of lymphoid tissue for your Peyer's patch. And all that really is that it's little nodes so that they can attack places faster, because that's where all your immune cells are going to come from. But this stuff attacks that. there is a vaccine that's used worldwide. And this thing does cause systemic infection, which is one of the reasons why it's so bad. The U.S. does have 2 vaccines that we use. One's an inactivated kill vaccine, one of them is live attenuated Beacon vaccine. The oral vaccine is 4 pills, I believe. 1 pill every other day. If you're going to do the oral one before you go someplace, you need to make sure that you complete the oral one at least 10 days prior to you going somewhere in order for it to actually protect you. And the injection is 1 injection, but the injection should be done should be completed at least 2 weeks before you go, so that it protects you. Big differences between the 2, besides being one live and one get attenuated, is that the live one, the booster is every 5 years. The get attenuated one, shot, is every 2 years. So you keep that in mind, depending upon how frequently the person that you're giving the vaccine to is coming and going, where they're going to and from. None of these vaccines are 100%. Okay, none of these vaccines are 100%. So just keep that in mind if people are going somewhere to get it with typhoid. Okay. Most incubation periods, usually most folks are asymptomatic, don't even realize they got something. All right. So you can always remember that. And then it really depends on how much organism you ingested, your immune status, medication use. So there's a lot of depends on the average 7 to 14 days before you actually get it. And there it goes anywhere between 3 days to 60 days a month before you actually get it. This can cause transient diarrhea. During the beginning phase, it can be coming and going. But that first week, usually you'll just get headaches and malaise and rising beginning fever. And what that means is your fever, then you stop, you plateau, and then you get a little bit higher fever for a couple of days, usually 3 to 5, and you plateau, and you go up again a little bit, 3 to 5 days, and you plateau. That's what that stepwise fever is. That's what that rising remittent fever is. There's generally 3 phases of typhoid fever. Usually you'll have your invasive phase, which is usually the first week, which is what the headache, malaise, and remit fever. And then you have your plateau phase that usually lasts 2 to 3 weeks. And then you have your convalescent phase, which usually occurs on the 4th week. So the stuff can last a month or so. Okay. So here, day 7 to 12, it's already your second week. Okay. I would highlight cross of 2 to 4 millimeters diameter pink papules, rose spots. Okay. You take a little slide and you push on them. They kind of blanch and disappear, and when you let them go, they come right back. And they're usually found in your upper torso, right, or your upper abdomen. And then you end up with relative bradycardia. Okay. And it's usually a combination of a couple of different things, where you have your central nervous system involved, your autonomic nervous system is kind of out of balance, you have toxin release in your system, you have cytokine over-inflammation going on, and then you have electrolyte disturbances. All that's causing relative bradycardia because it's making your heart not work appropriately, right? Because remember, when you have a fever, your heart rate goes up and your pulse rate goes up. That's what happens. But when your autonomic nervous system is jacked up, your cytokine inflammatory issues are blowing your body up, your body doesn't know how to respond. In this case, it's causing you bradycardia, which is a little different than what normally happens. The other thing that it does is it causes dichrotic pulse. And that's, what that means is that it's two pulses. Okay? So, okay, so your pulse is like this. That's your standard pulse, right? Goes along with your heartbeat. But now that your heartbeat's dropping, you're gonna end up with a dichrotic pulse, which gives you two waves. It'll give you a you're gonna feel in your pulse. That's the dichrotic aspect of the pulse, because your circulatory system supports the pulse. So, two more things that definitely highlight the type 1 because they're a little bit different than everything else. A lot of time that relatively low bradycardia is giving you that low blood pressure, and it's also causing your valves not to work right, which is shooting off with a chronic pulse. This is what rose spots look like. So here, part of your second week, right, you're gonna end up having a toxic appearance. You'll be apathetic. That just means that you're going to have lack of interest, enthusiasm, or concern about anything. You're not going to want to do anything. You just okay. Sustained paresthesia. Okay, your fever that you have is going to be consistent. It's just not going to go away. Okay? Your abdomen is going to be slightly distended. Right? You have that slightly distended abdomen because everything in your belly is swelling up. Particularly your small intestines and your lymph nodes within those small intestines. Okay, and then you'll have that splenomegaly. Why? Because it's attacking all those cells. And those immune cells are usually housed in the spleen. Your liver is also getting jacked up at the same time. Okay, so here, your third week, increased toxicity, so you're going to look worse. Okay, considerable weight loss because by this third or fourth week, you're probably not eating or drinking. Okay? The fever's still going. At this point, your fever's gone long enough that you're probably about 104. Sustained long periods of fever will usually cause you delirium. See what happens. It's called the typhoid state. Right here. And then one next thing to highlight, well, we have some abdominal distension, right? We just talked about that, but liquid, foul, green, yellow, diarrhea. Okay, something big to highlight, but that one's different than all the others. You guys remember about the bilirubin and the neurobilirubin, stercobilirubin, right? So in this case, they're having some issues with the stercobilirubin because the liver's getting jacked up too, and it's not fully pushing out appropriate bile into, well, it's getting pushed into the bile, but the bile is not completely conjugated appropriately, so as it goes into your intestinal system for the rest of the conjugation to occur, as that stercobilirubin gets into the fecal matter, it's not wholeheartedly turning it brown. It's coming out more greenish. Okay? And because everything's not being processed right, when it comes out, it's sticky. Okay? So you got sticky boots. Right? And there you've got weak and frayed pulse and tachypnea, right? You're trying to compensate. And usually within this time period, if you don't address it, it's usually when this person could die, anywhere between the third and fourth week. Okay. This fourth week, patient survives. Here it's got 50% mortality rate. Okay, all the symptoms slowly resolve, fever, mental status changes, not an issue. Okay, the convalescent phase, the danger from typhoid fever or paratyphoid fever doesn't necessarily go away. Okay? Here, the symptoms technically disappear, but they can relapse. Okay? The relapse usually occurs within 2 to 3 weeks after they get better. Okay? So that's one of those big things that you need to keep an eye on, is the 2 to 3 weeks status post them getting better. Because at that point they can relapse. Now, here's the problem with this phase. And And here it tells you you may have some intestinal complications. Right? Remember, anytime your intestinal lining is jacked up, you may have intestinal complications after you get better. Right? It's going to take you a while to get better after you cleared the infection. Right? But within this relapse stage, women, more common than men, this stuff lives in the gallbladder. This stuff usually lives in the gallbladder. Okay? So you can become a carrier of typhoid fever, be asymptomatic, not even realize it. What does that mean? That means if I'm nasty, and I go to the bathroom and I wash my hands, and I go and make you a sandwich, give you a sandwich, I'm spreading, possibly spreading, the typhoid to you. Okay? So here it's got that story with Typhoid Mary. And we'll talk about that next. But people that are usually that have to be cleared by providers, that have to be cleared by docs, are healthcare workers, food workers, childcare workers. If you do have typhoid fever, because you have to keep that in check after you're done to ensure that you are no longer harboring or carrying typhoid in your system. It could be that paratyphoid or that typhoid salmonella type. Right? If that's the case, we'll probably give you some antibiotics for it, right, to make it go away. Because those particular folks are dealing with other people, and if they're not doing hand hygiene properly, they're going to spread it to a lot of other people. Which is what we don't want. Now, Typhoid Mary's story, back in the early 20th century, I believe, she was an asymptomatic carrier. She used to cook for a living. This is one of those stories where public health did a great thing, right? So she used to cook for a living. All of a sudden, they started noticing a whole bunch of people in this one little area get sick. People were like trying to figure out what's causing the problem, what's happening, why is everyone getting sick? Public health came out and they figured out that Mary was the person of interest, spreading stuff to everybody. So they caught her, put her in jail for a little bit. They're like, hey, Mary, you're the person who's spreading everything. Look, we'll let you go. You just got to promise that you're not going to cook anymore for people because you're making people sick. He's like, okay, not a problem. So when she got out, she went and she started doing laundry. She started doing laundry service. And I'm assuming she did not like the laundry service business, because for a little bit, this is what she did, and then all of a sudden she went back to cooking. And then the same stuff started happening again. They started having clusters of sick people, where they realized, hey, look who's cooking again. And after that time period, they still went in jail. She spent a long time in jail after that. Okay? So carriers may spread this stuff to people, especially if you have no good hand hygiene. Some disagree. All right. So lab's diagnosis: most patients are anemic. Okay, their bone marrow is being affected, their liver is being affected, so they're having some clotting issues. Okay, ESR is going to go up because it's an inflammatory problem, thrombocytopenia. They're trying to block off the issues that are going on. Your LFTs are going to be up because your liver's jacked up. Relative lymphopenia because all your immune system is trying to fight everything off, so they're all getting beat up and dying. Okay. Definitive diagnosis: usually isolation of the organism found in blood or bone marrow. We don't really do bone marrow stuff anymore. That's taking a big needle, jamming through your skin, through your muscle, through your fat, into your bone, into your marrow, sucking that out. That is very invasive, so usually we just do blood. All of these, I'll say all of these, a lot of these have PCRs that are attached. You may be able to get a PCR if a PCR is available. Not on here, but if there is one, you can order that. Treatment is usually Cipro, ceftriaxone, or azithromycin. Okay, so look at the second two, ceftriaxone or azithromycin, if required in the label. And we have to understand that some of these things are starting to become resistant to our medications. And because they're resistant to our medications, we have to use different types of medications depending upon where in the world they're catching these things. So if we're talking typhoid fever because they've gone to Southeast Asia, ceftriaxone and azithromycin, they work better than Cipro. And a lot of these are finding fluoroquinolones that start falling to the wayside because resistance is being formed to a lot of fluoroquinolones. And Cipro being that main one that we usually use for a lot of diabetes stuff. So whenever we send off culture for these things, like I said, hey, just do a culture sensitivity because at least if they do realize that it is resistant, it's not working for the medication that you gave them initially, then they can specifically tell you what drug you need to give in order to help. Shigella. Sony or Flexneri. 90% of cases are silicosis. Two mechanisms. They attack the colon epithelium and they produce endotoxins. So they're attacking the epithelium in your intestinal tract, okay, one. And then they're also producing toxins that are going to end up attacking your system as well. They're doing multiple things. So out of the two types that we have there, Sony and Flexneri, Sony is usually in the U.S. here, and you can find that here. And then Flexneri is usually in underdeveloped countries. So if a person's coming back from an underdeveloped country or a developing country, their likelihood of having Flexneri is a little bit different than if they got it here, where they may have Sony. Right? And it's transmitted just like the other ones, fecal oral, and food or water. And close contact person to person can spread also because this is very contagious. Incubation period is usually about 3 days. And there it tells you approximately 50,000 cases in the U.S. annually. So it can be a big deal. The same, very contagious because it only takes anywhere between 10 to 100 virons of the organism to actually make you sick, just like the other one. Okay? Some of these, it only takes a little bit to get you sick. Okay? Acute bloody diarrhea. Okay? I like that. Okay? Shigella, acute bloody diarrhea. Okay? You end up with tenesmus, you saw that in a whole bunch of the other ones. Passage of mucus, you can highlight that. You haven't seen that in some of the other ones, right? And some of the other symptoms are included. There are fever, nausea, vomiting, tenesmus, and possibly blood, and diarrhea, right? That's usually blood. So something that's a little bit different than some of the others. Right? Fever can happen within 3 days after exposure. Self-limited course. 3 days to a week. Rarely lasts longer than a month. Okay? Lower abdominal tenderness when you're doing a physical exam. Right? So make sure you push on the belly. There it says normal to increase belly sound. So if you're listening to the belly, it may be gurgling like crazy. Right? The big thing here is that look, it goes anywhere from 3 days to 1 week, most common, right? And rarely greater than a month. Whereas you have to remember, right? Less than 2 weeks is acute. Greater than 4 weeks is chronic. So if we're talking this thing is going more than 1 month, either we're not treating it right, or we need to start treating it. If this thing does not get treated, right, this thing can cause significant dehydration. And with significant dehydration comes the electrolyte imbalance, circulatory collapse. And when we deal with those two can lead to death. But right? Remember the folks that are at risk, those little kids. Usually with this one, it's usually little kids less than 2 years of age. Okay, so here's some diagnosis. Okay, positive finding in stool culture. If you're gonna do a stool culture, please do a culture sensitivity, because that's gonna help you out, and what you're looking for. See, it's somewhat invasive, so you are gonna see some leukocytes and erythrocytes in your stool. Treatment, self-limiting. If it does get bad, if it does last longer than those 2 weeks that we're talking about for acute, I'll say just go ahead and treat. All right. But again, your choice. If you want to treat the mild stuff as well. Just remember, we do have some resistance across the world, so we gotta be careful on giving out antibiotics. Now, that statement there that says avoid narcotic-related anti-diarrhea, that statement goes for all diarrheal cases. That statement goes for all diarrheal cases. If you are going to do narcotics for diarrheal cases, that's the wrong answer. What is one of the number one things that narcotics do to your intestinal system? It stops you up, right? Causes constipation. That's wonderful. Now I got Shigella in my ass, and it ain't going away, right? Now it's staying in my system. Now I'm getting worse, right? So, number one, the constipation aspect. Number two, what's number two?
You can't feel it.
Say again?
You can't feel the symptoms.
Correct. You are masking all the symptoms that you have, which means when you ask these questions, what kind of things do you have? What kind of signs and symptoms do you have? Nothing. Nothing hurts anymore. Wonderful. You're cured, right? And then they start turning jaundice, and their eyes blow up, and they start turning red, right? So, hey, no narcotic stuff for any of your abdominal diarrheal issues. All right, let's stop right here. And we'll take a break. Talking about more specific E. coli, we're going to talk about ETEC. Good? All right. ETEC, EPEC, EIEC, and EPEC. Okay. The two that we have here for EPEC is generally childhood diarrhea stuff. It usually attaches to the lining of the intestinal underneath the watery diarrhea. It's literally usually causes abdominal cramps, fever. Nothing big. Usually supported treatment. That's all you really need to give. If it gets really bad, then usually we'll give fluoroquinolones with an understanding if the fluoroquinolones don't work, if maybe there's some resistance, we can do culture sensitivity to stool, and then they'll tell you what specific stuff you're going to use. Trimethamphetamine really is pretty good for that, and usually helps. The other one is EIEC. Remember, Shigella-like. Right? It invades the intestinal lining, causes inflammation and damage. Right? Shigella-like means that they may have bloody stools, right? Shigella-like. And they'll also have abdominal cramps. Okay. Treatment is technically the same. We're going to do fluoroquinolones in this case instead of sulfamethoxazine. We'll do azithromycin. But those two, just general overview, we're really going to concern ourselves with ETEC and ETEC. So ETEC being traveler's diarrhea. Remember, so if anyone goes to those endemic countries, they're going to end up coming back with possibly traveler's diarrhea, so they end up coming to see you. Usually traveler's diarrhea comes from endemic countries with lower income or lower socioeconomic countries, or countries with poor hygiene and sanitary issues. Okay. The infection usually occurs when a person eats food or drinks water or ice contaminated with ETEC. Humans or animal waste are ultimately the source of ETEC contamination. So again, sanitation and hygiene, huge. Okay. So there you can see a bunch of countries: Africa, South Asia, Latin America, Middle East. Okay. Most of them may have some abdominal cramping and frequent explosive bowel movements, right? Explosive bowel movements. You'll feel like you have tenesmus, right? You feel like you gotta go, but you just can't go. This stuff usually develops over 1 to 3 days after exposure. Usually lasts 3 to 4 days. It may take weeks or longer to resolve depending upon the strain or the individual person's immune system. Okay, this is your worldwide distribution. All that red is bad. Okay? So if your patient is going to any of those places, keep in mind you need to give them a heads up about traveler's diarrhea. Or if they come back, they may have traveler's diarrhea. Okay? Typically, this is just a clinical diagnosis, as are most of these. Okay? You could do a lab culture, if you like, of stool. Not necessarily what we do. Treatment, supportive. All right, there's the controversy right there. Loperamide with 1 antibiotic. If the person is bad, the person appears bad when they show up in your office, then yeah, by all means, go ahead and give them some antibiotics. If it's been more than 48 hours, then it's okay. You can try doing some loperamide, but again, just be a little bit wary. You could do antibiotics without the loperamide if you'd like. It doesn't have to be together. A lot of times the folks usually give loperamide because it is an explosive type diarrhea. And they're like, all right, let's go ahead and try to calm it down some. So we do a loperamide. 2 antibiotics that you can possibly use would be your azithromycin and ciprofloxacin. And here you can see that they're kind of flipped. In most of the cases, it's usually cipro first and then azithromycin second, or trimethoprim supplementary. In this case, azithromycin is on top because of more resistant four-dose fluoroquinolone. So be careful. Other things to keep in mind when you're thinking about doing a loperamide, which would be that anti-motility or anti-diarrheal, would be if the person still has a fever, don't give it to them. Right? Because obviously they still have the infection in their body. You don't want them to keep it inside their system. If they're having bloody diarrhea, yeah, don't give it to them, because obviously it's more of a systemic issue that you want to knock down before you actually start stopping the diarrhea issue. So those are 2 big no-nos with the antidiarrheals. If they have those 2, don't give it to them. All right? They also have a Metcolo. Okay. I have not seen that in the military pharmacy system. What that is basically a short 3-day course of antibiotics that solely target traveler's diarrhea. Okay. But again, I have not seen it in the military pharmacy. So we can say we have something that is actually FDA approved for traveler's diarrhea, particularly non-invasive traveler's diarrhea. Non-invasive meaning that there's no blood in the stool. Okay? But I have not seen anybody use that stuff. Not actually not having it as part of our formulary. Okay? The civilian sector may be a little bit different. It's newer and it's very niche, so the cost may be a lot more expensive in the civilian sector for National Guard and Reservists. Okay. Hey, remember 015787. Remember 015787 is probably going to be on your test. Okay. The reason why I tell you that, this is a bad one. Okay. This can cause pus. Okay. Also, it's hemolytic uremic syndrome. That's bad. Okay. This thing produces stuff like Shigella toxin where it actually eats away at your intestinal lining. It destroys a lot of your intestinal lining. Okay? This is a gram-negative bacterial E. coli. And it causes acute bloody diarrhea. That may lead to hemolytic uremic syndrome. And that's basically a serious condition that affects the blood and blood vessels. Lead to the destruction of red blood cells, low platelet count, and kidney failure. That's literally what HUS does. You'll learn more about that when you get to GED next semester. The diarrhea may last 1 to 8 days, bloody type, if it's uncomplicated. Okay. And there it tells you death, in some cases 3 to 5%, if patients end up with pus. Okay. Most common cause of renal failure in children. So not good. This is just like the other ones, spread by contaminated food or water. Usually in this case, more common is cow manure infection of the food in the water. For us, undercooked beef or unpasteurized milk is a way for us to get this. Okay. Usually the undercooked ground beef and burgers are one of the bigger ways to get this. Okay. Now this is fecal orally, especially among infants in diapers. So inadequate chlorination of pools with little children in their diapers in those pools can spread this. Chlorination in that water is usually not high enough to kill the E. coli. Right? So little kids wading in pools may spread it. The pus usually affects children less than 5 and then the elderly, greater than 60. Right? And that stuff usually ends up developing after the second week of starting E. coli. Definitive diagnosis, stool culture. And if you're going to do that stool culture, make sure you do a culture sensitivity when you're doing it. Usually they'll put it around that sorbitol conchiometer, which is really what we use. Treatment is usually supportive and typically resolves without therapy. Alright, so here, if you're giving antibiotics, some of the antibiotics that you may give usually are processed through the kidney, and if the kidney is being jacked up by the hemolytic uremic syndrome, what you're doing is you're making things worse, which is one of the reasons why they say do not use antibiotics with this. Right, so the main antibiotic that we usually use is fluoroquinolone, right? It's flucloxacin. Okay. That generally may increase the enterotoxins, okay, which makes hemolytic uremic syndrome even worse, especially with children, usually less than 5, and the older folks are usually older than 60. So don't use that. There it's telling you no antidiarrheals. Okay. No antidiarrheals. And if it is pretty bad, when we know your kidneys are jacked up and they're not working appropriately, then usually we'll set you up for dialysis. Cholera. Contaminated water food can lead to severe water diarrhea, vomiting, dehydration. Okay, I want to accentuate severe. There it says cholera is brief for flow, cholera is what the infection is, but it says death can occur within hours of infection due to massive dehydration. If you're going to remember anything from cholera, remember rice water stools, where you're filling up a bucket every time you go to the bathroom. Usually it's clear, usually you'll have white flecks in it, which is why we call it rice water stool. If you remember anything from cholera, that's really what you need to remember. Because you are losing so many electrolytes and so much fluid, that stuff can kill you pretty fast, especially if you're an infant, right? With an understanding of where the endemic countries usually are that this occurs in. Right? They're usually underdeveloped countries that can't handle a lot of these things. So you do end up having quite a bit of this. And it usually affects the small bowel. It's a gram-negative bacteria, cholera. Usually secretes a toxin somewhat similar to the Shigella toxin. Okay? That causes a lot of watery diarrhea. incubation period is usually 1 to 3 days. Here's a whole bunch of outbreaks, okay? Not gonna be on a test. All right, so here, painless watery diarrhea, rice water, appearance of fishy odor, and a fishy odor. So I would highlight that. Quickly becoming voluminous, I would highlight that. Because those are real hallmarks for cholera. Usually you don't have any fevers, because it's generally not an invasive issue. It's just covering up your intestinal lining from absorbing fluids, and it's opening up the junctions, allowing electrolytes to bleed out into your intestinal tract. This is generally what that bucket on the right, that's one time for one person going to the bathroom. Usually clear, cloudy, and if you can see there's little white speckles in it, okay, that's the rice water that they usually talk about. So it really looks like rice water spooks. Okay. And if you look to the right, that's usually the clinics that they're working in, right? So there's not tons of stuff. Do you think there's a sink in there for hand hygiene? So remember, some of these things we have to put into context depending upon where they are. Right? So we say high mortality rate because we go to places like this where they can't do a lot of the things that we generally do here in the States. Right? So keep that in mind when you think about some of these things if you're going to be practicing overseas. Right? So treatment is bolded in all big capital letters, supportive care with fluid replacement. They can drink, have a drink, and we give them IV, give them IV. Okay. Antibiotics in short and course, you got 2 there. These are a little bit different because now we're adding doxy in there instead of Cipro. And we've got azithromycin in there. Mortality rate is very high without therapy. Right? Because we have to understand the folks that are actually affected by this. Usually we can do a culture or serology, but by that time frame, it's a little late. Prevention is key. Prevention is key. Okay. We have a vaccine for this. Usually we don't use it here, but we do have it approved by the FDA for the Air Force folks who are going to be working with the global health engagement teams. This may be something that you may want to think about. Depending upon where your folks are going to go overseas, they're going to be exposed to some of this. That vaccine should be available for you, and it's used for folks anywhere between the ages of 2 and 64. All right, listeria. One of the main reasons why you need to remember listeria is because it's really bad in pregnant women. You have your little list there of at-risk folks, right? Elderly, neonates. But this is really bad in pregnant women. Okay. That is probably one of the bigger things you need to highlight here with listeria. This is caused by food, right? It's foodborne illness. Right? The food's not done right, you just spread it. It can commonly be found in soil, water, some animal products, and usually what happens is some of those animal products end up getting contaminated during the food processing portion, and then that's what comes out to the general public. Alright? If you guys haven't heard Boar's Head, I like Boar's Head. They just had a listeria outbreak like 4 months ago. Okay, where they had to recall a whole bunch of their stuff. Right? So when you look at this, the foodborne illness, dairy, especially unsaturated milk, soft cheeses, ice cream, raw fruit, vegetables, and produce, hot dogs, cold cuts, and deli meats. Okay? Those generally harbor, if not processed appropriately, listeria. Okay? A lot of times it usually just presents as diarrhea, but it's a lot worse in pregnant women. Now, there it says Hispanic women more than 24 times 24 times more likely to have this problem. Right? And we always try to figure out why. Why are these people like this? Why are they more predisposed? Right? Because this thing can kill your baby. So what they have found is that their cultural dietary practices are generally what leads them to be more susceptible to this. And this is where it becomes, hey, you really need to know your individual patient. You know what they're doing, right? What social economic class are they kind of in? That's going to tell you what kind of foods generally they eat, right? The lower the socioeconomic, the cheaper the food that they're going to eat, right? If they find something that's not as good, but it's cheaper, they're going to get it because that's what they can afford, right? So we have to keep those things in mind. And this is one of the reasons why Hispanic women are usually more prone. Okay? And as always, you've got your immunocompromised folks. This thing usually attacks the lining of the small intestines, just like typhoid does. Okay, so here's some other presentations. Okay? Usually are uncommon and rare, but if Listeria becomes systemic, right, it can cause some meningitis, abscess formations, endocarditis, it can affect your heart. So it can affect a whole bunch of different things if it becomes systemic. Okay. So, key word here is non-invasive. Right? Non-invasive means it's not going to become systemic. It's not even away to walls of your intestinal lining. Okay. And in this case, it'll be fever, myalgias, arthralgias, and back pain. Okay. So here's some neonatal presentations. So you'll have an early onset and a late onset. Early onset usually within the first week of life. Right? So as you're born, usually within that first week. The late onset is usually 1 week or more. So you can spread this transplacentally, which means while the baby is in utero, you can give it to the baby, which is usually why you have a high baby mortality. Okay? If the baby is born, you can have sepsis, pneumonia, meningitis, fever, poor feeding. There's a lot of things that baby can have, but usually the mortality rate is extremely high in neonates if it is passed in utero. Right? If it's a late onset, a week to 28 days after birth, okay, you're going to have the same symptoms. It's just going to develop later. Then it'll start getting worse, but you'll also have some other muscle aches, that meningitis and septicemia that you didn't notice initially when that first week is now probably full-blown systematic, and it'll be a touch and go. And so here are some symptoms for neurologic signs. Right? As you said, if this doesn't become systemic, it can affect any other organs. If it does affect your central nervous system, mental status changes, seizures, cranial nerve deficits, stroke-like syndromes. Right? So they're all nervous symptoms. Particulitis is inflammation of the ventricles in the brain. The ventricles are fluid-filled spaces in the brain that kind of cushion the brain and allow fluid to flow through your brain, so it protects your brain. So, standard blood cultures, if it is neurologic, will only give you 60 to 75% positivity rate. If it is neurologic, due to a CSF, dual lumbar puncture, okay, barring they don't have any intracranial pressure going on. Right? If the area that you're working at does have PCR, then by all means, it's not on this list, but by all means, use PCR because we have PCR to detect Listeria. It may not be everywhere, but usually most larger facilities have PCR now. If you are one of those facilities that still has wet maps or microscopes, and you do take a look at the sample, that little guy, that Listeria organism, is going to look like it's tumbling across your view, across your field of view. And that's one of the ways that we denote the difference in Listeria when we look at them. It's a tumbling motility index. treatment for at-risk populations. Usually we'll treat empirically, right? Gotta be treated empirically or not. Symptoms can be invasive, so you have to be careful, so we treat sooner rather than later. And ampicillin is safe for pregnancy. Ampicillin is safe for pregnancy. Trimethoprim, sulfamethasone is not safe for pregnancy. One of the things that I would suggest for you guys to do when you guys get to your well woman clinics, one of the first questions I would have you ask them is, do you guys have a list of the medications that are safe for pregnant women? This way, you guys can have a little list so that you guys can refer to it later on in your career. I still have my little list from my well woman rotation, and I carry my pharmacopoeia if I'm dealing with someone who's pregnant. So I can look at what medications are going to be safe for them. Okay? It's category A and B is really what we want to go with. Anything greater than that is at risk. Okay? Okay, botulism. This is rare, but a serious illness. Okay? Ingestion of food that has been in cans. You don't hear that very often anymore, but also may occur with dried or smoked meats or fish. Okay? This thing releases a neurotoxin. Okay? And it's produced by that bacterium, Clostridium botulinum. This neurotoxin can cause muscle paralysis and potentially lead to respiratory failure if left untreated. Okay? And botulism can be acquired through consuming contaminated food, canning stuff, wound infections, or inhaling the toxin. Right? And here, home can is a way to get it, but not too many people that do that anymore. Wound botulism also occurs in IV drug users from injecting black tar heroin. So for those of you who are going to work in the emergency department, urgent care, this becomes a big issue, right? Folks that are injecting that stuff that end up in your ER, one of the things you need to think about is botulism. It prevents release of acetylcholine, which is why it causes the paralytic effect. Right? The neurotoxin is what causes that prevention of release of choline. Okay, pediatricians recommend not giving honey to less than 1-year-olds. Okay. It's a risk to the infant. Those botulism spores may be in the honey. That is the reason why they say, hey, probably no honey to less than 1-year-olds, because they may not be able to handle it. Right? So signs and symptoms for infants typically appear 12 to 36 hours after consumption, may appear from 10 to 14 days later. So you have a little window there. Right, and what they're going to look like, they'll be lethargic, poor feeding, constipation, weak and crying or muscle tone. They'll look like floppy babies. Okay? If you don't know what a floppy baby is, just pick a doll up and it just hangs with no movement. That's what a floppy baby looks like. They may have some facial weakness. If you do check their gag reflex, they may not have a gag reflex. Those babies need to be in hospital. Right, here's some signs and symptoms for adults. Usually kicks in about 72 hours after ingestion. Right, sudden severe weakness. Okay. And here's the key. Right, so you can highlight this aspect. Sudden severe weakness with intact sensation. So although they're weak, they still feel everything, considering this is supposed to be a neurotoxin. You can have diplopia, ptosis, facial weakness, dysphagia. There's a whole bunch of different other signs and symptoms. They're usually symmetrical. That's another thing that you can probably remember. Those neurologic signs are usually symmetrical. This is a notifiable one. You need to let the authorities know if you have a botulism case. And you can do toxins, obtain the toxin from serum samples. Or if this is something that you think that they have from home, sometimes what they'll do, especially if you're thinking it's a canning thing, or it's a food thing, they'll go, public health, not you, will go to the house and they'll get the food or the cans and then they'll take that off the line. Person with this really should be hospitalized because of the respiratory possibility. Right? They're going to start not breathing, you may have to put them onto a chest tube, onto a respiratory tube to help them breathe. And you could possibly do an EMG, not always done, just to make sure that, especially with paralysis, to make sure that this stuff is still going on. Generally, we won't read those EMGs, that'll be a neurologist doing that, but it is a way to know that that person's still, motor nerves are still being conducted. All right, so treatment-wise, there are two different types of antitoxin things. Okay, so you have the hepavalent equine botulism antitoxin, and you have the immune globulin potassium channel antagonist. Alright, either of those, they're going to stop that toxin from spreading. Right? They're going to stop it from making things worse. They're not going to make it better, they're just going to keep it from getting worse. Now, that baby usually goes to infants less than 1 year of age. Okay? This is a specific antitoxin used for infants. It produces passive immunity by supplying antibodies to the baby. All right? And it's the same thing that either the pentavalent equine botulism or the immunoglobulin does for the adult. Those two are for the adults. The egg is for infants less than 1 year of age. Okay? So we need to separate those three. First two are for adults, third one is for babies, less than 1 year of age. Okay, so remember that the primary treatment involves administering antitoxins to neutralize some of the botulism, and then generally supportive care. Okay, generally supportive care, the person's going to be in ICU with a tube, we're going to help them, that you're going to help them breathe. All right. And there at the very end, it tells you, hey, you actually do have a wound botulism, NG or metrodiazole. Okay? So it is something on your body that you can see on your hand, most common, then you can do NG or metrodiazole. And this is just things you can ask a returning traveler, right? From some of those in different countries. You don't want to look like that guy, so make sure you do prevention as best you can with your patients. Okay. We're going to start with viral hemorrhagic fevers. This is pretty cool because I actually like these guys. I don't know if you guys have ever heard of the Hot Zone. It's a non-fictional book, but it was actually written by a person that talks about the impact of deadly diseases such as Ebola. Okay? With an understanding that, hey, if I have Ebola, I can take a plane ride anywhere in the world and be someplace in less than 24 hours, and I can spread my Ebola to everybody. So a lot of these viral hemorrhagic cases, we have to remember that it's a short distance flight, cruise, drive to someplace else where we can actually spread some of these things. This book really talks about the history of Ebola and the outbreaks and the science behind the Ebola virus. It's pretty interesting. Right, so these are some of the things that we're going to talk about. Okay. So viral hemorrhages, they're generally a group of diseases that are caused by several distinct families. We'll talk about those families on the next slide. But they affect many organ systems of the body, damage overall cardiovascular system, and reduce the body's ability to function on its own. Right? So usually we can get this stuff by inhalation, insect bites, mucosal membranes are usually infected, but one way that they get in Direct contact with someone else will be another way that we can possibly get these. But it usually affects your macrophages, your dendritic cells, and your monocytes. So they're usually the three cells that these viral hemorrhages usually attack. They attack them at different severities. Sometimes they'll attack one, not necessarily all three, but they all also attack your endothelial lining of your blood vessels. Okay? And you guys remember that stuff from the first block. That causes a weakening of the junction of all your vessels, which means now you're going to start leaking stuff out into your body. Some of these, they leak out in specific places. Ebola probably being the worst because it leaks out everywhere and it causes organ damage or organ failure. Okay? For none of these, okay, none of these do we have any cure or vaccines for. I'll take that back. I think we had a vaccine for Ebola, but only one of the 6 strains. All right, so this is kind of the breakdown that we're looking at. Okay, we have Bombardier, that's Crimean Congo, hemorrhagic fever, and Hunta. Rhino viridae, that is Lassa, that one's usually spread by rodents. Okay, Guillain-Barré is usually arthropods, human to human, and animals to human. Fileroviridae, which would be Ebola and Marburg. Usually it's human to human or animal to human. And then Fileroviridae are usually arthropods like ticks and mosquitoes. And that would be dengue and yellow fever. Okay, so we're going to talk about some general stuff here. All of these are RNA viruses. All of them. Okay. Because they're RNA viruses, what can we use to figure out what they are? RT-PCR, correct. If we have it, use it. If we have it, use it. Big reason why I say that is because it can differentiate the speciation of some of these things. Okay? And it's good for early diagnosis. Some of these will tell you, hey, do serology. Remember, serology has a window, right? It's going to take your body a couple of days or a week to kick in before you start noticing some things. But at least with PCR, it'll give you a better chance of diagnosis early on stage. All right? All damaged microvasculature. So we just talked about. Because all of these damage microvasculature at the blood vessel level, they're all gonna leak. They all just leak in different manners. Some leak more than others. Some leak only in the mucosal areas, right? But understand that they're all leaking. Survival is dependent on host reservoir. We don't know who can survive some of these and who don't. Ebola is a primary example, right? How do we know which person who gets Ebola is going to be the person that survives? Because we really don't have much to give. We don't. Whoever survives is the person that survives. They're going to have some complications after that, but hey, guess what? They survive. Why? We don't know. Okay. So there's a lot of that with some of the viral hemorrhages. Right? Humans, we're just natural reservoirs. Okay? Humans can transmit virus to one another. That'd be the Ebola being one of those people. And usually, we're the ones that end up causing outbreaks of this stuff. So we sometimes just don't know. And there's no cure established for drug regimen for most of these viral hemorrhages. Here's some concerns. Okay. We're reservoirs or nothing else. Okay. Keep track of the mode of transmission. The mode of transmission is going to be one of the main ways that you can denote what some of these things are. Right? That's going to be extremely important. The region of where those people are or work It's gonna be another clue for you to determine what they may or may not have. Okay? Presentation and treatment, obviously. Some of these have some specific things that we can go through and highlight when we go through, so that if you do see them, we can, like, oh yeah, it's probably this. And understand that morbidity and mortality for some of these are like really, really high. And some of the diagnosis, some of the pathology that we've already talked about. All right, so we'll talk about dengue. Okay. Dengue can spread through the blood transfusion. Okay. Organ transplants into needle sticks. Not just the mosquito, Aedes aegypti or Aedes albopictus. So 2 different mosquitoes. Do we have both those mosquitoes in the United States? Yes, we do. Yes, we do. Have we had dengue in the United States? Yes, we have. Is it a big problem now? Not really. Right? We've done a lot of things in public health and the environment to try to knock down a lot of these diseases here in the U.S. But understand, these mosquitoes are not born with this virus. Okay? What happens is you, the host, get infected with the virus somehow, and then a mosquito comes and bites you, and now the mosquito's infected with the virus. Then he goes and bites somebody else, and then he just passes the virus on that way. Okay? And that's usually for most of these. That's usually the way it works in malaria as well. Mosquitoes aren't born with the virus. They get it from you or someone infected, and then they just pass it on. Okay? And that's usually what happens with this. They just passing it on. There's 4 specific type of serotypes of dengue. Okay? So there it says no cross-protective immunity. Dengue 2 is probably the worst one out of the 4. But if you get 1, it does not protect you against 2. If you get 2, it does not protect you against 1, or 3, or 4, which means you can get other types of dengue, right? Because we're talking about 4 different serotypes. So here's the problem with that. If you get 1 serotype, you may have some immunity towards that serotype for a couple of weeks to a couple of months, to maybe a year or so. The stuff, your immunity protection wanes over time. So guess what? Over time, you may be susceptible to another dengue. Say you had dengue 1, you may get dengue 1 again. Okay? So it's kind of rough with the dengue. Right? Okay, so remember the mosquito, Aedes aegypti, or albopictus. All right, look at that. Look at the 35 north, 35 south. All right, 35 north. If you look at a map, usually it's about the lower third of the United States for those mosquitoes, and about 3/4 of the way down in South America. If you follow the longitude lines of 35 north and 35 south, those whole tropical and subtropical areas is usually where we'll find this thing. So if you follow those lines all across the globe, right, you'll see all the other parts on the world that have this as a possibility. And they're domestic. Domestic means that they hang out in large places where humans hang out, and they are day biters. So note, when they're deployed, and we tell you, hey, keep your sleeves down during the day, right, when you're outside, not just for you not to get any sunburn, but if there are these mosquitoes, because they are day biters, they don't bite you. Right? It's more so for your protection than it is anything else. Right? So here's some dengue fever symptoms. Look, it may be asymptomatic. Right? Kind of nice. Or you may have some non-specific febrile illness, right? Fever of unknown origin. Ooh. Right? See, some of these symptoms can be complex. All right? You can have fever, typically high fever. Okay? Severe headaches, pain behind the eyes, and we'll talk about that with the next slide on the real ones. Those you can probably highlight, right? Because you're not going to really see those too much. You have pain, rash. The big thing with this slide is if you have dengue, can recover, not an issue, not a problem, right? You may have some complications, it's the way it works. Here's the problem with dengue, aside the serovars and not having lifelong immunity. If you get dengue again, and usually more common in children, usually less than 10 years of age, if you get dengue again, you are more prone to end up with dengue hemorrhagic fever, where you'll have more bleeding complications. Usually more common at the second occurrence of dengue, usually in children. Now, the problem with that hemorrhagic aspect of this is that it is the earlier stage of dengue shock syndrome. Right? With shock, we're talking collapse of the circulatory vasculature, right? So as you're bleeding out, that's going to lead you to your DSS, okay? To your dengue shock syndrome. So first you'll get DHS, and that may lead to DSS if you're not treating it. Usually, second go around, and usually in children less than 10. Here's a whole bunch of cases. Here, look, Texas 3 cases in 2020, Florida 45 cases in 2020, in 2019, Florida 6 other cases. Right, so does it happen here? Yes. When I was working in Florida at Baptist, we saw a couple. Okay. Saving grace is that we had doctors from overseas, so a lot of them are a little bit more astute than some of us U.S. providers who are not used to seeing some of these things. Okay. So just things to keep in mind, depending upon where you are, is what's going to be most common. Right? Here's your map of your Alopictus in your 80s. Okay. Now, remember, these mosquitoes can also spread other things. You guys know what Zika is, or chikungunya. Those mosquitoes can spread those things as well. Right? So it isn't just one thing that these guys can spread. Here's a bunch of military operations that have occurred. Look at a study of 500 U.S. Army Special Forces soldiers during 2006-2008. Found antibodies against dengue in 11% of samples. So people have had this. Okay? We have had it. Okay? Here's more stuff. These aren't going to be on the test, right? They're all stats, just to let you know that stuff is happening. Here's a whole bunch more. Right? According to the World Health Organization, 50 to 100 million people are infected annually. Right? VHF, hemorrhagic fever, right? 250 to 500,000 of these individuals. That means that those individuals have probably had dengue at least once. Okay? 24,000 deaths. All right. Let's go ahead and take a break. Headache. How many kids have had retroorbital pain? None. None have had retroorbital pain that we talked about thus far. That is very common with dengue. There's the highlight, right? Because that's probably some of the things that we have put on there. You may have truncoscarlatine-form rash, right? And some of the leaky vessels that are going to make it to your skin. You may have some severe myalgias or arthralgias, hemorrhagic manifestations, small amounts of bleeding, those are gums, usually most common. Usually when you do your oral physical exam, you'll see the gums bleeding in patients like this. Okay? They may throw up if you look a little bit of blood. Abdominal pain. That fever can last anywhere from 2 to 7 days, right? So if we're talking 107, 105 for 7 days, those guys can be delirious. So things to keep track of. Okay, fever abates for a day or so. Okay, and returns, that's what we call saddleback fever. And usually what happens is usually you've got a high fever for 3 to 5 days, then you're good. You don't have fever again for another 3 to 5 days, and then you're good, and it'll continue on. On average, it usually lasts for about 8 waves or so. But even with 8 waves at such a high temperature, that's pretty bad. Okay? And look, risk for development of DHF or DSS at approximately the time of defervescence. Defervescence is when your fever abates or stops. Okay? Once you're done with your fever, at that point is when you think DHF may begin. All right? So keep that in mind. A severe dengue is a medical emergency. Okay, physical symptoms. Okay, you'll have rash in palpitations, scarlatiniform macular papula. You'll see that on their body. You'll have petechiae purpura, conjunctival injection. Okay, 1/3 of patients with DHF. Pharyngeal injection, almost 97% of patients with DHF. Congenital lymphadenopathy or hepatomegaly. Why? Because the liver is part of what's being attacked. This is what subconjunctival hemorrhage looks like. This is what purpura looks like. And this is what a scarlatina-form rash looks like. So hemorrhagic manifestations, generally petechiae. Remember, if you're going to draw blood on this person, because this person is probably bleeding because they have what we call capillary fragility, okay, right? Those epithelial cells or endothelial cells are being attacked, so they're fragile. If you're going to give them a stick with a needle to draw some blood, okay, you have to remember that this person may continue to bleed out that little stick that you just made. Okay. Other hemorrhagic manifestations you may see will be the nasal or gingival areas, which we talked about, and then may have some melon or hematosis. Okay, this is on average what gingival bleeding looks like with David. Okay. You see that he's got like a mouthful of blood there on that little spacer on the side of his face, but his mouth is generally covered with blood. Okay. It's not gross blood, like spewing, spitting everywhere, but you're going to notice it when you just take a look on physical inspection. So you'll see it spitting blood out. But nothing extreme. Now, probably tell you to remember this slide. I like this slide. The reason why I like this slide is because we will not always be working in an area where we have everything we need. So this is what we call the tourniquet test. Right? It doesn't tell you whether you have dengue or not. Right? But what it does tell you is whether or not you have capillary fragility. And that's really what you're looking at, right? All these viral hemorrhages are causing capillary fragility. And that's literally what you're testing with this tourniquet test. Okay? So what you're going to do is you're going to take one of those tourniquets from the wall for your blood pressure cuff. All right? You're going to put it on the arm and you're going to crank it up. Here it says midway between diastolic and systolic. I say at about 100 or higher, or a little bit higher. You don't want to do a tourniquet effect. You just want to cause some extreme pressure on the arm. That's all you're doing, is causing extreme pressure on your arm, decreasing a little bit of that vasculature of the blood vessels going through, of the blood going through all the blood vessels. You're decreasing that pressure a little bit, not tourniquet effect. Okay? You're going to hold that for like 5 minutes. And then what you're going to do after the 5 minutes is you're just going to open the little thing back up and let it go. What that's going to do is it's going to hold, it's going to rush all the blood that was being held by the tourniquet forward into the arm. If those blood vessels, right, think mechanically, if those blood vessels are fragile, all that extra pressure that was being held by that tourniquet is going to get pushed forward, and it's going to push on those vessels. And if they are, it'll create a whole bunch of petechiae in that area. And the magic number here is it's positive within a 1 by 1 inch square on the skin. If you have more than 10 petechiae within a 1 by 1 inch square on the skin, that is just telling you that you have capillary fragility. It is not telling you that you have dengue. Okay? But you know something's going on. Okay? If you're in the middle of nowhere, this is what you think is going on. You do the test, and you're like, yeah, you probably have some sort of hemorrhage, something. Okay? We have no PCR, we have no serology, we have nothing else. Okay? This is something that we always have, right? Because if you carry an egg bag, blood pressure cuff's probably one of those things that you have in the bag. If not, probably your medic has it. If not, your MES kit and outfit has it. Okay? So that is something that we always have. Okay? This is what some of the pecan skin look like. And so look at the right side. The right side kind of looks more like a scarletine rash. The left side, if you draw a 1 inch by 1 inch square on there, you'll probably have more than 10 petechiae in there, which means he probably has some sort of capillary fragility going on. Okay? Whether it's dengue, we won't know unless we do specific testing. All right, so what can we do? CBC, right? You're going to see the leukemia. Right? You have fever, you've got stuff going on, white blood cells are going to go up, lymphocytosis, okay, that's going to go up. Okay. Rise in hematocrit. Why is there a rise in hematocrit? Because your blood's leaking out, right? Everything's leaking out of your vessels. Your hematocrit's going up. The hematocrit itself is not leaking out. So you're going to have some sort of hemoconcentration. As your plasma leaks out from the blood vessel into the surrounding tissue, that's going to increase. Here to tell you monitor for DHF, DSS every 3 to 4 hours. Okay. Platelet count's going to be down. Right? It's trying to stop all the leaking. Right? You can do a basic metabolic panel. Hyponatremia is one of the common things you see because your sodium is leaking out. Okay, you can do liver functions test. Okay, your LFTs are going to be off. Generally, your AST will probably be higher than your AST will be higher than ALT. You'll have low immunity. Okay, it's part of that hemoconcentration. You can do quad studies. The quad studies will be more so for the PT and PTT, right? Because your bone marrow is getting affected and your liver is getting affected. The liver makes all your coagulation factors. So your PT, your PTT, and your INR are going to be all jacked up. So a whole bunch of stuff you can do there. Okay. Here it just tells you, like, if your hematocrit is increased and you have hemoconcentration, that just means that you're leaking. Okay, that means your vessels are leaking. But if your hematocrit drops, that means that you're bleeding. There's a difference between active bleeding and vessel leakage. Right? So that's what this slide is trying to tell you. All right? Okay, here's some labs that you can do. You can isolate the dengue virus. They put on here paired serum samples. You can do one initially and then you can do one like a week later. You can see if there's a 4-fold increase or not. Then you can do one a couple of months later or a couple of weeks later to see if there's any continued increase. If you do have RT-PCR, that is your best bet. Okay? Your best bet for RT-PCR, I never tell you during the first week of illness, because this will pick it up early. If you do serology or if you do anything else, it's not going to pick it up if you're trying to find it early. Okay? Your serology, your ELISA, your IgG, IgM have to develop to at least 5 days is what it says. That RT-PCR or NS1, that NS1 is really a detector of protein that's secreted by the dengue virus into the blood. So that NS1 is able to find the viral protein for dengue earlier rather than later if you have RT-PCR. It's another one that you can do early rather than late. If you do it late, and NS1 may not work because that viral protein will no longer be in the bloodstream for dengue. Or at least the specific one that it looks for may not be in there. So look, self-limiting. Okay. Symptomatic treatment is really what we need to do. Now, if it does develop into DHF or DSS, probably should be hospitalized, probably needs IV fluids, may need a blood transfusion depending upon what's happening, right? Make sure that you denote the difference between hematocrit loss versus hematocrit concentration, because that'll tell you whether they do or do not need blood. Threshold blood is preferred, so that would be probably something I would highlight. And then do not use steroids. They have not been found to be useful in dengue. So prevention is key. Here's the vaccine, dengue vaccine, in some countries. That is approved by the FDA, so we can use it here in the U.S. So that is something we do have, something for you to think about. That particular vaccine does provide protection against all 4 dengue strains. Dengue 1, 2, 3, 4. Usually 3 doses over a 12-month time period. Now, some of the other things some of the other parts of the world have done is they've done GMO mosquitoes. So they try to eradicate it that way. Down in the Keys, here in Florida, they did not want to do that. They are not sure if it's going to affect the ecosystem, and they're trying to keep the ecosystem as safe as possible. So no GMO mosquitoes down there. Key point, nothing greater than 30% of DEET. Nothing greater than 30% of DEET. Start going beyond 30% of DEET, number one, it hasn't shown any serious effectiveness difference between up to 30%, and it also may cause some neurologic side effects. So nothing greater than 30% of DEET. Okay? With little kids, make sure you don't spray it on their hands, because you don't want them to put that stuff in their mouth. Okay? Try not to spray it on areas if you have like abrasions, broken skin areas. Try not to put it into those areas, because then you may end up having some other side effects or some severe reactions, like nausea, dizziness, or skin irritations. Okay, here's some complications of dengue: neurologic manifestations, encephalitis, Guillain-Barré, transverse myelitis, liver failure with DHF and DSS, and overhydration. Right? You have to be careful of giving them fluids or blood. This is what happens with the overhydration. Okay, here's some differentials. Okay, there's more possibilities of what has occurred with dengue. Okay, so just to point out, okay, the Aedes aegypti and Alopecia do spread other things such as Zika and chikungunya. Zika, the biggest thing, we'll mention that a little bit later, but Zika, the biggest thing is pregnancy. Right? Just like listeria, pregnancy is the biggest issue with Zika. Usually it's self-limiting, but if you're pregnant, your baby may come out with some issues or it may cause spontaneous abortions. Chikungunya is a lot more similar to dengue, and it is a mosquito-borne disease. Right? It can cause issues with fever, joints, muscle aches, headaches. All these are day-biting mosquitoes, and they're all domestic mosquitoes, so they all hang out in urban areas where we hang out. So like we're spreading it pretty high. We don't really do anything for any of these guys. Okay? Symptomatic care. Okay? We really don't have any meds, so usually we just tell them to rest, stay hydrated. Basically it. Take acetaminophen. Nothing more, because there's no antiviral treatment for this thing. Right? The next one we're going to talk about is yellow fever. Okay. 2 types. You have your epidemic, or your urban Aedes aegypti mosquito, or your Slavonic jungle version. Your Slavonic or jungle version is usually spread by monkeys or by wild mosquitoes other than just Aedes aegypti. When we talk about urban stuff, that's us in communities and cities where they hang out at. And that's us being in a closed group with a whole bunch of people where we can spread it to ourselves, mosquito. Right, there's a whole bunch of outbreaks that happen there. Okay, you can see that there. There is a vaccine that's been around since 1937. Okay. We use it here. I've taken it multiple times. The stuff does protect you up to 10 years, vaccine-wise. Okay. So the thing has been shown to be effective. But again, none of these things are 100%. Okay. Most of these cases are usually in Africa. Most of these cases are usually in Africa. Okay. So here's the area of South America that has yellow fever. Okay. That includes, if you look in the upper left corner there, the lower aspect of Central America, particularly where the Panama Canal is at. Okay. And here's the areas of infection for Africa. Approximately 90% of these cases are usually found in Africa versus anywhere else. Okay. So here, big deal. Right? A female mosquito regurgitates the virus. Right? So, just like I mentioned before, the mosquito isn't born with the virus, it has to go bite somebody with the virus, and then it goes and bites somebody who doesn't have the virus and expresses the virus. That stuff usually goes into their gut, it manifests in their gut, and it comes out into their saliva. When they bite you, they spread. Okay? It usually affects your vasculature, your endothelial cells, just like all the other ones. This one is no different than the other ones. Okay, I think the biggest difference with this one than the other one is that this one is more attached to a little bit more of the reticuloendothelial system. Okay? And that system is very specific for removing foreign substances, old and damaged cells, and waste materials from your bloodstream. But it still attacks the same exact cells as the other ones, macrophages, monocytes, and dendritic cells. Things to highlight here, probably that black vomit. Okay, mucosal and GI bleeding, black water vomit. Okay, is a big thing. Okay, usually you'll see yellow fever in 3 different stages. The 3 stages are going to be the period of infection, the period of remission, and the period of intoxication. All right. So during the period of infection is the acute phase. Okay. Usually happens 3 to 6 days after inoculation. Right? So after they bite you, 3 to 6 days later, you probably end up with some of these. Fever, headache, nausea, bilious, vomiting, right? Bilious, conjunctival injection. Okay, here's a nice 85% of this stops here. 85% stop. You don't go beyond this point. You're great, your body handles it, you're good, right? But there's folks that continue on. Right? Still got another 15% to go on. So you end up with a 24-hour remission stage. So it's like, okay, I feel better. I'm good. 24 hours or so, you're okay. And then all of a sudden, you go into your intoxication stage. Okay? And your intoxication stage is when all the bad stuff happens. That's when your liver gets all jacked up and the rest of your body starts getting jacked up. So if you look in your upper left, you get your jaundice, your oliguria, your dark urine. Right? It's affecting your liver. Same stuff that we talked about before. Right? You end up with petechiae on the skin. Right? You're losing out, you bleed. Right? Usually occurs 3rd to 6th day after onset of the infection. Okay? There's a lot of viral replication going on, generally within the liver, okay? Causing a lot of liver dysfunction, which is one of the reasons why you end up with decreased coagulation factor and jaundice. The other place that it's really affecting is your spleen, where all your immune system cells live, right? The macrophages. You can look at the skin where they turn yellow, right? Jaundice. You can look at the sclera, right? You remember what the sclera was, right? You'll see in these cases, it'll also turn yellow. Okay? So you'll have a lot of serious issues with this. This one, okay. This is probably the second one that we've seen that has relative bradycardia, right? But remember, the relative bradycardia is usually from that cytokine release of the extra inflammatory reaction in the body. It's attacking that muscle in the body, and the heart's not sure what to do, especially when we're talking, this person has fever. So remember, so if you want to highlight that one for this one, that's the second one that has relative bradycardia. Okay. So what are we going to do? CBC, same deal. We're going to have leukopenia, thrombocytopenia, hemochromatosis. Nothing different than any of the others, right? We do a coagulation study, right? We're affecting the liver. The liver does all your coag factors, right? 9, 10, 11, 7. Right? You can do chemistries, right? You need to check for your electrolytes because as your vessels leak out, you're leaking out a lot of electrolytes. As you lose electrolytes, whether it be sodium or potassium, that also affects your heart, right? The sodium potassium pump, right? So if you do have a PCR, then you can go ahead and use PCR. And then there it's telling you check the liver because the liver is going to be jacked up. You can do ECG and cardiac monitoring, right? Because we're talking sodium potassium loss, we're talking attack of the vasculature, which goes through the heart. We're talking attack of the vessels of the heart. So now we're going to check for that stuff. And there it says serologic studies including convalescent. So we'll do some initially and we'll do some later. Usually about 5 to 7 days, your choice. You do up to 10 days. And then after 10 days, you can also draw another IgG to see if it's getting better or getting worse. Along with your acute convalescent times. Okay, treatment. I will tell you to highlight active bleeding, right? And I will tell you to highlight pressure over plasma. Okay. In that toxic phase, right? You're not really eating, you're hypotensive. You probably end up becoming hypoglycemic. Right? That FPP, that pressure over plasma definitely can help. Dialysis if needed. You may want to isolate and use mosquito netting for your patient. So when you're taking your patient someplace, if you can put them someplace, when we talk about mosquito-borne illnesses, if the mosquito has to bite somebody infected and then bite somebody healthy to spread it, you want to use that mosquito netting to protect the mosquito from getting to that infected person so he doesn't continue to spread it. That goes for all these mosquito-borne diseases that we talk about. Okay? Because if the mosquito does bite somebody infected, then it's going to go off and bite somebody else. Okay? We're going to continue to get more and more patients, which is what we talk about. Right? If you don't really have a severe form of yellow fever, usually you're better within 7 days. On average, a week or so. Okay? To deal with a lot of these, because they're self-limiting, your recovery phase is going to be a lot longer than a standard recovery phase. Because this thing did affect a lot of your inflammation. Okay, so it's going to take a little bit to get back to it. Right? So we have no effective antivirals for this. Immunization and education is key, right? Prevention is key. That's what we want to do if we possibly can for folks that are going to go over that. And I seriously doubt that we can avoid mosquitoes, but we'll do what we can. All right. Just remember that that vaccine for yellow fever has been around for almost 80 years, and we have not had any serious issues. There's a book about the Panama Canal, the way they built it, and about how many people died doing it. one of the biggest issues that they have is yellow fever. So we can see in that time period, because yellow fever vaccine was not available during that time period, to now, yellow fever has dropped drastically with the use of vaccination. Usually the vaccine is used for kids 9 years old. Okay, so here's a bunch of complications, here's a bunch of differentials, okay? So you can be smart if somebody asks you questions. So these two we're going to kind of clump together, all right? Marburg is Ebola's little cousin. All right, Marburg, same type of stuff. Marburg is just a little milder and doesn't last as long as Ebola. Okay? Here's the problem, here's the big difference. Same type of species stuff, but we don't have anything for Marburg. Marburg is usually in East Africa for the most part, not too many other places. It's a lot milder symptoms, a lot less. It's not as easily spread or contacted to other humans. But the things that we have to help Ebola, which you would think, okay, if we're talking same species, we're talking the same type of mechanism, why wouldn't it work? Apparently it does not work. We have, I think, 2 things that we can give for Ebola, but they do not work on Marburg. And when we get to the end, I'll show you the quick difference with the treatment. The meds that we have for Ebola just do not work for Marburg. Both of these are generally found in sub-Saharan Africa. Okay. Ebola throughout sub-Saharan Africa, Marburg more on the eastern aspect of Africa. Okay. There are 6 different subtypes of Ebola. I want you to remember Zaire. Okay. There's Zaire, there's Sudan, Typhorus, Bugio, and Risto. Do we really care about any of the other ones? We kind of sort of don't. Because the main culprit and the worst one that causes most of the outbreaks of Ebola is Zaire. Zaire gives you up to 90% mortality rate. Okay, Sudan, the next one, gives you up to 60% death rate, mortality rate. Okay. So I don't really care about the other ones. I think the last 2 are kind of questionable whether they affect humans or they think they're more animals. But just understand Zaire is the worst one of the bunch. And that is really what we targeted the treatment for Ebola. The other big thing that you really need to know is the cultural beliefs and the challenges to educate and treat, right? This happens most commonly in a place where education isn't one of the primary things that they really do. Okay? They do have things that go out and try to educate a lot of the populace, but understand the entire populace isn't as educated as developed countries. So we have to understand their cultures. Within that culture, you have multi-generational families living under one roof. Okay? They help each other, they take care of each other. Okay? And when we talk about something like Ebola and Marburg, any of the bodily fluids that you have can spread Ebola or Marburg. Got it? Any. It is highly contagious, highly infectious. So if you're laying there and your grandmother's taking care of you, wiping the blood or the stuff that's coming out of the side of your mouth, okay, and they're not taking care of themselves, and if they have breaks in their skin, they just got Ebola too. Okay? These are some of the cultural things that we have to keep in mind when we're looking at those areas of the world that are being affected more so with this particular bug. All right? This one not just targets macrophages and dendritic cells, this one also targets natural killer cells, T cells and B cells. So it targets more stuff than some of the other ones, which is why Ebola and Marburg are a lot worse than some of the other larger issues, because it starts targeting a whole bunch of different cells. Okay? Targets a lot more. Along with the epithelium of the endothelial cells of the vasculature. When you look at this slide is only telling you the most common is the fruit bat. Okay? Fruit bat is what they think is a natural reservoir for Ebola. Okay? Different kinds of fruit bat for Ebola versus Marburg. That is one of the differences. Okay? The type of fruit bat that spreads it. They think the fruit bat affects some of the bushmeat, can affect some of the primates. Humans go out and either eat some of the infected bushmeat or interact with some of the primates, and that's how we start spreading. Right? This is what we consider a filovirus. Over there, we do have microscopes. We do have a microscope, and you start looking at this. This is going to look like a little string. Okay? It's going to look like the vessel of the back of the eye. Right? This is some places where they have had outbreaks. Okay? Uganda for Marburg, Uganda for Ebola, Democratic Republic of Congo for Ebola. Right? Remember, these are not on the test. Okay, so here's some big outbreaks. Okay. Yeah, they were doing temperature checks over there, but a whole bunch of places still got infected. Okay. Spring 2217, Zaire Spring, Democratic Republic of Congo. Right? These are not on the test. Okay. Just to let you know, stuff's still happening. DRC had an outbreak of Ebola in the summer 2020. Right. So there's a little layout of a lot of the common areas in Africa that have had outbreaks of Ebola. Okay, you will get like a hemorrhagic rash that appears over your entire body that looks kind of sort of like that. Remember the face of this guy. It's expressionless. What we call Hippocratic or ghost-like faces. His face is just staring out into the wilderness. Nothing. No facial expression. That's what they're going to have. Usually you'll see this a lot later in the disease, not initially. Okay. This is what a gentleman looks like with Ebola. Here's a little kid. Right? So when we talk about those cultural things, right? Grandma or little brother or sister or auntie is taking care of this little kid at the house. Okay? And that fluid that's coming out of his mouth that they're probably going to wipe off with a rag will have the viral particle on it and spread. So then the rest of the family starts spreading. The World Health Organization has tried to start doing educational teams to go from place to place, educating people when they see certain symptoms, what they should do. Okay? This is one of the things that they're doing. Okay? They're trying to sanitize the area before they take this gentleman overseas. Okay? It's probably where he lives, and they're probably taking him someplace to isolate him. Alright? This is a little kid with Ebola in intensive care. You can see he's bleeding out. So here's some physical signs early in the disease. Severe headaches, meningitis, arthralgias, myalgias, fever with or without chills. Okay. You can also have those gastrointestinal symptoms, abdominal pain, nausea, diarrhea. So you're going to have a whole bunch of different things. A whole bunch. And this goes along with bleeding. Okay, especially out of any of your mucus, any of your mucocutaneal areas. Okay, so later physical, there's your expressionless, Hippocratic ghost-like face. Okay, bleeding from any of your mucous membranes or puncture sites. Okay, you may have some GI bleeding as well. And so that kidney is going to try to compensate for that blood loss. You are going to look bad. Okay? You're going to look bad. Tugged really just means that you're having altered mental status. You're not as alert as you should. And uritic just means you have a medical condition and you're unable to produce urine. Kidney, you have that rapid, shallow breathing because you're trying to compensate. You're losing a bunch of blood, you're trying to compensate, you're getting rid of the bad stuff, and getting oxygen. It may be normal for us at this point, okay, so not necessarily feverish. That hiccups, I wouldn't necessarily spend too much on that. They say when people are about to die, usually they end up getting hiccups. I haven't really seen too much of that in the literature. And this person usually ends up with circulatory collapse, alright, in shock, because of the loss of blood and fluids. And this one's just like the other ones, right? CBC, you're going to have thrombocytopenia, you're going to have the leukopenia. So you can do a chemistry panel, you can do liver function, both of them will be off because you are losing a lot of your electrolytes, your liver is getting jacked up. Okay. You do end up having lactic acidosis build up in your body because your muscles are getting jacked up. Because you can't clear that. Because your kidneys are also having dysfunction. That's going to end up leading you to that metabolic acidosis. You have increased blood and serum creatine because your kidneys can't clear stuff. Your kidneys are getting jacked up. And then remember, if you're going to do serum ELISA, you're going to have a little window there up to a week. And then if you can do PCR, do PCR. All right, so here's the importance for all of this. The side on the left is a treatment for Ebola. The little box on the right where it says Marburg treatment, supportive care only. Right? No monoclonal antibodies and no vaccines. There is nothing that we have that we can give Marburg folks other than supportive treatment that will make them better. Okay? So if you look at the Ebola treatment, right, supportive is the biggest thing. Carrier isolation, make sure that you put them someplace where they can't spread their bodily fluids to other folks. Okay? You make sure you wear your PPE. Make sure they stay hydrated. Make sure that they continue to eat, even if you have to give them a feeding tube, TPN, right? Because they're not going to want it. Right? So you can give them human convalescent plasma. What that is they've taken plasma and IgG from people who have survived Ebola, spin it, and then give them the good stuff. Does it always work? No. That's part of the problem with human convalescent plasma. Okay. Depends on when you give it to the patient. If it's not as bad versus being extremely severe, it may not help that much. The patient that has survived, they have spun that IgG from for the human convalescent plasma, may not have enough in there to actually help protect the individual. Okay? So when you make a choice between a monoclonal antibody and a human convalescent plasma, our usual choice is the monoclonal antibody because we know, number one, we're probably going to have enough. Monoclonal antibodies are done in a lab. I can make more. Human convalescent plasma is dependent on the individual patient that has survived. Did you have enough? Did you get it right? Did you spin it right? Depends on what time and space that individual patient is given the human convalescent plasma, or whether it's going to really help or not, right? Because both of these, whether it be the human convalescent plasma or the monoclonal antibody, is only going to give you passive immunity. Okay? Remember, passive immunity is only going to keep the thing from getting worse right now. That's all it does. It's going to allow your body to hopefully help itself without allowing that disease process to continue to get worse. That's all the monoclonal antibodies and or the human convalescent plasma is doing. So you have those choices there. You have two different choices for the monoclonal antibodies. You have the Ebanga and the Imazib. The Imazib has 3 different monoclonal antibodies. You would think that that one would be better than Ebanga, but in all reality, they're still pretty equivalent. Now here's the thing. Both of those are very specific for Zaire strain only. They are both for Zaire strain only. Why have they targeted that? Because 90%, right? Target the most, that causes the most problems. That's what they target. Because it's for Zaire only, it's probably the main reason why it does not affect Marburg. Different strain. And then you do have Everbo, and Everbo is a live attenuated vaccine that the FDA approved back in 2019. It only covers Zaire strain. The vaccine only covers Zaire strain for greater than 18-year-olds. We don't generally use it here. Now, the CDC team that usually go over there and help treat some of those Ebola outbreaks may take some of this stuff. Generally, not routine immunizations for us. Okay? So we don't usually mess with that stuff here. All right. Here's some complications. Ebola 80% death, Marburg 25% death. Okay, you will have some ocular manifestations. Okay, if you look at that bottom bullet just above differential, some have been found to have billions of copies on PCR and virus lurking in their anterior chamber of their eye for 3 months after illness onset. It has even been found in semen weeks after the infection has resolved. Okay? So one of the things that we need to mention if we're talking to survivors is that they need to come in every couple of months to check their sperm to see if they have Ebola in their sperm. Okay? They can't spread it sexually to another person via the sperm. Right? Any bodily fluid can spread Ebola or Marburg. This includes sperm. So that's a real big one. Usually we tell them, hey, don't have intercourse for at least a year. You need to come in until we clear you from all this virus stuff. Okay? There's a bunch of differentials, and this is where we're going to stop. All right. I will see you guys.